Morning. Welcome to the October 16th, 2014 Public Health Nursing ITV. So glad you could join us this morning. It's a busy time for everyone in public health, I know. My name is Joy Hoskins. I'm the Director of Nursing as well as the Division Director for Women's Health. And so it's an honor today to bring two speakers who will present to us and bring to us a wealth of information. One about Bridges Out of Poverty, which will be a vastly interesting presentation. If you've not had the opportunity to hear Benita speak or have participated in the Bridges Out of Poverty overview, I think you'll truly be impacted by what she has to share with us. Then secondly, Captain Doug Thurman will be joining us to share his personal experiences from his recent trip to Liberia. He has a lot of pictures as well as a lot of epi information, clinical information about Ebola. And I know that you'll be very interested in that information as well. So what I'll do next is go ahead. We've got a very tight agenda. So I want to go ahead and introduce Benita Decker. Benita is the Adolescent Health Coordinator for the Department for Public Health, and I get the privilege of working with Benita every day as she's housed in the Division of Women's Health, and she has Bridges Out of Poverty is one of the many activities and initiatives that Benita is involved in. So she's a certified Bridges Out of Poverty trainer, and so she went and received this training. And this actually, it could be an 8-hour training, is that, or 2-day? How long is
8 hours to 2 days?
Yeah, 8-hour to 2-day training. So I asked her if she could come and share the Bridges Out of Poverty information with us. So this is a Reader's Digest condensed version, a 2-hour overview of what she's able to share with us. And so thank you, Benita, for taking time out of your busy day as well and to talk to the public health nurses. I'll turn it over to Benita.
Thank you, Joy. And I also get the privilege of working with Joy every day. She is a wonderful supervisor and a great boss. And so I really am thankful to have her in that role. Thank you all for coming. What we're going to talk about today, let me get my presentation up. We're going to talk about Bridges Out of Poverty. Bridges Out of Poverty is actually a framework. It is a concept. It is not an exact program. It is something that can be taught and used in a multitude of ways. And so we're going to talk about that in a little bit. But I wanted to show you, there's a book called Bridges Out of Poverty that was written by Ruby Payne. If you've ever done any kind of out of poverty type of stuff, Ruby Payne is the queen of that. And then her staff, which is basically Philip Duvall and Terry DeRusi Smith. Terry's been in our state multiple times doing some trainings, some all-day trainings. They wrote this book together, and it is a powerful book that can work across any continuum, actually. So today we're going to talk about that. I'm going to give you an overview, and we're going to talk fast and hard because there's a massive amount of information. And I'm just actually, even though you're going to be a little overwhelmed in the end of 2 hours, it is something that takes days and sometimes weeks for you to absorb and to apply, but it is information that you can apply to your work as an individual, to your health department as an institution, and even to your community as you work as community partners, and we'll look about that. Now, this training is meant to be a little interactive, which is really tough. I'm glad I have my ladies and gentlemen out here right in front of me. But you all in ITV world, thanks to the unmute button, can also participate. And so there'll be times when I'll be asking you to think about some things. We'll take a pause as we move into a section, and then we'll kind of have a little feedback. Please feel free to feedback, because believe me, you don't want me to lecture for 2 hours. And you'll really learn a little bit better when we do it a little more interactively. Joellen, we can switch to my slides. Okay, so today we're going to introduce the framework. If you get a taste of this and say, we want more, just contact me. My information will be at the end of this slide, and we'll talk about what an all-day workshop looks like, where we expand the information and digest it a little better through a day of work. So today, just in the next 2 hours, we're going to speed through, we'll spend some time in mental models of poverty, middle class, and wealth. But then we're going to look at some hidden rules and how important they are. And we'll talk about the 8 resources, which are actually now 11 resources. And we'll talk about that too. We're going to try and get those in at the very end. And they're so important. And so but as you can see, that's a lot of stuff that if I got to take a whole day, it would be a lot, you would learn a lot more than what you're going to learn today. But I think you're going to have some aha moments. So like I said in the beginning, the Bridges concept depends on what lens you're looking from. Let me grab my notes. So it can work on the individual level, which would be like someone who works with clients or works one-on-one with people in poverty. Okay, it can work from an institutional level where you design programs and maybe policies or actions from like the local health department level. So for program people, directors, that type of stuff, nurse leaders, you all may look at this from an institutional lens. And nurses and other people that are working directly with patients will look with it at an individual lens. And then you can also take this even into the community where you engage your community partners, your government, and look at it at this whole framework from a community lens. And through all that, you end up having policy changes. And some of you have already had policy changes. When you think about people who have open scheduling, that is a true policy change to help engage people in poverty. And so that policy change came about so that you could make your facility more acceptable and more accessible to clients. So let's talk about generational poverty as compared to situational poverty. There's a big difference, sort of. Generational poverty is when people have been in poverty for 2 or more generations. And so we have a lot of generational poverty in Kentucky. But we have situational poverty too. And situational poverty is something that happens because of some type of life event. There's the 3 Ds that are the major ones, which is death, divorce, and, well, what is the other D? Oh, and disease, an illness, a disease. But there's other Ds that cause situational poverty. So talk among your neighbors for a minute and think about some Ds that cause situational poverty.
This is what you were. Depreciation.
Okay, in the interest of time, let's talk about those. Feel free from the field to shout them out, but here in the room, I heard some. You all shout out some of the ones you were talking about.
Drug addiction.
Drug addiction.
Job loss.
Job loss, downsizing, you know.
Depression.
Depression, mental illness can cause poverty. In fact, most people, a lot of people, mental illness sets you up to be in poverty, actually.
Disability.
Disabilities, that's exactly right. Any other Ds that anybody came up with?
Disasters.
Disasters. Wipe out your house with a hurricane or tornado or a flood or a fire. Yeah, you're facing situational poverty. Very good. Anything else? How about the kids?
It didn't start with the D.
The kids. The college bills. You know, maybe some poor decisions. We've had people talk about domestic violence and other situations. So we can come up with a lot of Ds and a lot of reasons people end up in situational poverty. But if you're a child that's hungry on the streets, you don't care whether it's situational poverty or generational poverty, you're still a hungry person, okay? And so that's why it's important. Dr. James Comer, a worker with Bridges Out of Poverty and with Ruby Payne, says, no significant learning occurs without a significant relationship. You know, if we're not going to have relationship with the clients that we work with on some level, with the people we engage with, then we're not going to be able to teach them anything. And so I would like to take that further and say no significant health and wellness occurs without a significant relationship of mutual respect. Sometimes it's a us and them situation, and we just cannot look at it that way anymore. I imagine that some of you are sitting here saying either I came from poverty, I'm in poverty. You know, the middle class is shrinking, and so more and more of us are feeling that tightness and that fear of being in poverty. And I think you're going to find that a lot of that comes from what our resources are and how well we're able to wade through this financial mess that we get into, even in situational poverty, when you get a woman in divorce or someone who hits disaster. Resources make a big difference, and we're going to see that toward the end of this day. Okay, we're going to talk about some mental models. Mental models are internal pictures of how the world works, okay? Everyone has them. They exist below awareness. They are theories in use, and they're often unexamined. They're just adopted through learning and through experience. And they do determine how we act, and they can or cannot interfere with our learning, with our learning. Okay, and so when we can discover and analyze some mental models, it increases our depth of dialogue. It increases our understanding of each other, and which makes us be more meaningful and larger and more comprehensive than in our care. When we can look at each other through and knowing what the mental models are and just taking them and not taking them for granted. So when we talk about mental models, let's clean it down just a little bit more. Okay, it's a common understanding what it is like for individuals and families, and it's what we learned as families. For instance, they spring out of our experiences. The Great Depression had a great impact on our parents, our grandparents. And for instance, my dad, he lived through the Great Depression, and he was a World War II veteran and worked for years. And then when he finished one job, he went to work for the Disabled American Veterans in Northern Kentucky in Cold Spring. And this is in the 70s, and so what they did was that the national headquarters for the DAV is there, and at that time they sent out massive mailings. And so his thing was they put stamps on all these mailings and sent them out. Well, every day they would have tons of envelopes with stamps on them that they were just going to throw away. Well, my dad wasn't throwing away no stamps, okay? And so you saved everything. You saved every penny. You didn't throw anything away. So he would come home every night with his pile of anywhere from 5 to 50 envelopes with little, 2, 3, 4 cent stamps on them. And then he would steam them off, and we had coffee cans full of stamps that we glued. I was adult before I did Elmer's glue stamps, like 10 of them on my envelopes, because Dad said, we're not wasting a penny. That came from the Great Depression, from how his experience was in the Great Depression. And we can talk about other mental models. There are still mental models that come out from that include things around slavery and the African American experience, from immigration, European immigration, in the last century, Native American experiences. Those are mental models, and they derive how we exist and how we live our lives. So I want you to take out a scrap piece of paper, and we'll see how your mental models are working today. And by the way, if I said generational poverty, if I said some big concept, however many people in the room is, that's probably about how many mental models you would have of that. So we're going to see what your mental model is about the following 4 things, okay? When I say, I want you to just draw a quick picture, just a doodle, okay? When I say religion, what do you think of? Just draw it on your piece of paper. And when I say love, draw what you think of on your piece of paper. When I say divorce, when I say concupiscence, draw that on your paper.
Say that word again.
Concupiscence. You just want to hear me say it. Okay, Joy, will you flip to me from my slide?
Yes. Let's see.
Maybe.
Yeah. Camera. And you want me to go?
To me, I think it's one.
Yeah. Here you go.
Okay. All right. So when you try, yay, Joy, it's Joel Jr. Okay. When I say religion, what did you all draw?
Cross.
A cross. Anybody draw anything besides a cross out there in ITV world or anywhere?
Like the coexist.
Okay, the coexist symbol. Anything else? Okay. When I said love, what did you all draw?
A heart, lips.
Lips. Okay. Anybody want to chime in from out in ITV world what they drew? Okay, so love, we drew a heart, lips, anything else out there? Okay. When I said divorce, what did you draw?
A broken heart.
A broken heart,
Lightning bolt. Shock.
a lightning bolt,
Sad face crying.
sad face crying,
Also did a tombstone.
a tombstone. I've had people draw balloons in celebration. Anybody in ITV world want to comment? Okay, very different in your mental models a little bit, okay? And then how about concupiscence? Anybody draw anything for concupiscence?
Question mark.
I drew a pair of pants that looked like something was,
Going out of it, huh?
yeah, it looked like
My pen.
Yeah.
Concupiscence means, you're close, Mel. Concupiscence means a strong sexual desire. I'm an adolescent health coordinator, you got to pull that in. And so, it means, but it shows that you can't have a mental model about what you don't know, okay? You can't have a mental model about something if you don't know what it is. And so I think that speaks volumes. If we don't have a good mental model of what our folks in poverty are experiencing, then we aren't going to be able to be effective. And vice versa, if they don't have a good mental model of what's going on in middle class, and well too, I guess, they're not going to be able to interact with us, okay? People in wealth have very poor mental models of poverty. And so therefore, policies are made in wealth. It's really tough for them to do those accurate policies because they don't have a good picture of poverty, okay? Their mental model of poverty isn't accurate. So let's look at the mental model of poverty, okay? What I want you to do is talk between yourselves. We're not going to go because we've got time constraints, but just for a minute or two, talk among yourselves and jot down some things that you think about people you know in poverty, and what is a daily life experience for them. Talk about maybe people they interact with, some experiences for them, that type of stuff. So jot those down for a minute, and then we're going to talk about them. And Joy, we can go back to the PowerPoint.
We go back to you.
I go back. Oh no, we're good. You already went back to PowerPoint.
You're like always thinking about skin shelter. Right.
How do you spell it?
I mean, I always thought HIV, but now I think to the more we talk about it, I always think mental health too, because so many people are schizophrenic. So that's probably, I mean, I think to me that's probably why it's so scary. Because not a lot of people don't really understand what's going on. Like, basic human desires on that pyramid of basic needs, to want food and shelter. And if you don't really understand why you're not getting that.
Okay, so let's look. This mental model of poverty was created by a group in poverty in central Ohio, okay? And they were, so know that this is not necessarily everything. We might add some stuff to it, and know that just because it's on here doesn't mean that every person in poverty, of course, experiences this, but across the continuum as a standard, you see this quite a bit in a community. So we see things that they listed were clothing, debt, transportation issues, family and friends, safety is an issue for them, big issue, jobs. Don't think that people in poverty don't work. I think that's a mental model, and it's false. The problem is they work at minimum wage jobs or under the table for a little bit of money at a time. Health is an issue. We're going to talk more about that. Chemical dependency, mental health issues, housing, is criminal justice system, food, child care is different than it is in middle class. The children, how children are raised are different. Entertainment is big. Agency time is a big thing. We don't see agency time too much in in middle class, do we? It's all about relationships. Because they live in the tyranny of the moment, you're going to hear me say that a lot. People in poverty are in a survival mode. They live in the tyranny of the moment. They're just living from minute to minute, or at least day to day, okay? They depend a lot on each other to get everything done and get their needs met. And it's huge. Relationships is huge to them, okay? And so that's important that we know about that. Transportation always shows up in the pie when you're in poverty. You can't usually afford a reliable car. And so how many of you all are AAA members or have a road protection warranty on your car? Okay. Well, you can't afford that when you're in poverty. Okay. So your AAA becomes Uncle Ray. When your car breaks down, you call Uncle Ray. Uncle Ray comes out with his truck and his chain and tows your car away. And then he works on it in his garage so he can get it running again the best that he can so you can get on the road again. Okay. Transportation is always an issue in poverty. Okay. And again, just because we list all these, and we could probably list more. Anybody else come up with anything else that should go in this circle?
What about loneliness?
About what?
Loneliness. You say there's relationships, but for a lot of people, there are no relationships.
Right, especially when they get elderly or whatever.
Not even elderly.
Right.
I mean, they're just
Isolated. We're going to talk, that's really good, and we're going to talk more about that with resources. But yes, we can put loneliness in here. Anybody else want to put something else on there? We'll talk a little bit about that more in a minute, too. I'm sorry, what did you say?
Disease. I guess you could think of how scary it would be to get something that you either don't have money to treat or don't have time to go to healthcare.
Right, right. It's different. Now let's look at this. We look at this if you think about the middle class, which probably all of us, most or all of us are in the middle class culture. When it comes to people in poverty, health clinics they look at health clinics differently than we do, right? Social services, schools, police, religious organizations, and that people in poverty, because we live in this society in a middle class. All the rules are middle class. Okay, so when people in poverty deal with us in our clinics, our social services, that kind of thing, our schools, they see it as a them and us. They don't understand us. Okay, and it breaks down communication because they're about relationships. And they know that we don't get them and they don't get us, and so it breaks down that ability for relationships. Do you think people in poverty look at police differently than we do as in people in middle class? Absolutely. They spend a lot more time with the policemen in a different way than we do. Okay?
And then you need to meet.
Go ahead. Was somebody going to say something?
Talking about beauty
Okay. And social services is something that they do a lot with, and it's something either we work at or look at it as something that the people in poverty take advantage of, okay? But we don't spend a lot of time in the social service chair, do we? We're on the side providing the social services as middle class people, but they look at social services totally differently. Also, let's look at the businesses in poverty. The ones listed here are pawn shops, liquor stores, corner, stores, convenience stores, rent-to-own, laundromats, fast food, check cashing, temp services, used car lots, that pay-as-you-go type of thing, dollar stores. Although now we see some of these in middle class, do we see them in the volume that we see in our lower income class neighborhoods? Okay, in fact the check, there's a check cashing. They've put in, I didn't think it passed, but they're trying to outlaw check cashing places, or if they make that they can't be in certain neighborhoods. There is a bill that I think is coming up again. I read in the paper or something, because check cashing places that pay as you go, car pay here, buy here, pay here, car lots, that type of thing, really are there to take advantage of the poor, and so they're not a good thing. It just puts people more and more into debt and into poverty. Let's look at the floor plan of someone who lives in poverty. Okay, what do people in poverty that you know in your community tell you about their housing? We at the state, we don't get to do one-on-one like you out into the in the community, but I'm sure they talk to you about their housing. Are people sleeping in the living room? Are they couch serving? Somebody's coming in for a night and going away. Are people sleeping in the kitchen? Are they doubling up? Is the house overcrowded? Often, yes, because they're about survival, and they take care of each other. And they make sure it's about relationship, because I'm going to take care of you and give you a place to stay today because I may need you tomorrow. Okay, and so there's a lot of doubling up, and a lot of times in poverty, you'll hear them say, where are you staying? Not where are you living, but where are you staying? Because they know that wherever you are, it can be kind of temporary, okay? And it's a sign of, a lot of times if they say, no, we have a house or we have land, we have a place to live, that's a sign of that they have arrived to certain steps. Then everybody else is going to want to stay with them because they're stable, and so they got a stable place to stay. So what does a house plan of a middle-class home look like in a middle-class neighborhood? Is there only one person sleeping in each room, or no more than two if they're children, or married couple? How does it affect everyone's life? In the middle class, the floor plan often allows you to take a break, to spend some time by yourself, maybe reading, reflecting, just being able to be yourself. But in a poverty home, a lot of times every inch of every space is occupied. Okay, and it's occupied with busy people doing things constantly. There's always drama because there's a lot of people there. Okay, and so escape is very difficult. Time to yourself is very difficult. Escaping the drama is very difficult, and so it leads to a lower ability to learn. When you think about a child that's trying to do homework, okay, a child who's trying to read and get that assignment done. There's a lot going on. He doesn't have that particular moment, that time where he can escape and get his homework done. Plus, it's not a priority because there's so much other stuff in the house going on that gets shuffled to the bottom. Okay, so you can see where it really affects things like education. Health, you got one person with a cold, they're all going to get a cold. Okay, and so that type of thing. So in order to understand poverty, we've got to understand the larger elements that coexist with poverty in our communities. And many times families stay together to conserve resources. And relationships, again, is their best resource, because they need each other. Okay. If you did everything your caseworker told you to do, got a job and kept it for a year, never missing a day of work, how much closer, if at all, would you be to being out of poverty at the end of that year than you were at the beginning of the year? And so that question was asked by a group in Adams County, Pennsylvania. And I want to show you this video This video was done in 2009, so when you see these figures, pop them up because the cost of living has gone up since then. But it's eye-opening just in itself and worth watching. Hopefully we won't have it added. Can y'all hear? Powerful. Pretty powerful, right? Really important so many times, and I know people in poverty who don't work, okay, so I know that that exists, but don't think that just because you're in poverty that you don't work. You know, one of our mental models is that the people don't work. The reality is a lot of them work 2 and 3 jobs, but they just cannot, sometimes, some only work, but some of them work 2 or 3 jobs. We probably all can name people in our lives that are in poverty and work at least 1 to 3 jobs to try and make ends meet. But the work doesn't help them obtain economic stability. And there's a lot of factors there, not just because they lose benefits, although that's one major one, okay? But also how they were trained to spend their money. How were they taught, as you know, from the adolescent health perspective, how were they taught financial stability and how to be financially stable and how, where to spend their money? Because the people in poverty spend their money differently. They never can make bills ends meet. So they tend to spend a lot of their money on entertainment. How many people of us have been in homes of people who are living in maybe public assistance housing, or we know they're not paying their rent, but they got the biggest big screen TV in the community, okay? And their kids all have iPhone 6s, and they've all got the best of everything, and they're at the Red Box every day on their big, great Blu-ray, because it's all about entertainment. They know they can't meet those bills, so they take their money and spend it on things that give them entertainment. Entertainment is big in poverty, okay? And so that's really important. I mean, and also when I think about that as an adolescent health person, looking at teen pregnancy and looking at my rates when I lay my poverty map over my teen birth rates and that they're higher, where's a teen's incentive to get out of that when they know they can get the benefits they can get? And why work so hard to go through what this girl in Adams, Pennsylvania went through? I mean, it's an income for them, and it's a realistic, whether we want to judge it or not, there's no judgment there. It's income to have babies. And when you live in poverty, that's the way you're going to survive. That's the way you're going to, as an 18-year-old, that's the way you're going to get your housing and your food and sustain your life, okay? So, and that's a lot bigger than us, so, and I realize that. But I just wanted to bring that in about the wage part of poverty. Anybody, did I hear somebody want to comment out in the field? Okay, let's talk about health issues. There's a thing called the socioeconomic status gradient. It's a big fancy word that was actually developed by the World Health Organization. And essentially what it says is the richer you are, the healthier you are. The poorer you are, the sicker you are. Living in poverty is a risk factor for stress-related illnesses, and that's nothing new to anyone in this room or out in the field. Okay, it's not necessarily a lack of access. We know in Kentucky, we have all of our people in poverty have access to health care, okay, thanks to you all out in the field and us and us working together in public health. But it makes, and I have to say that with the Affordable Care Act, it's made a difference. But in America, our SES is very, very steep. The wealthy get the best treatment, the wealthy are the healthiest, and the poor. And what's interesting is that when you go into like European countries and other countries that have socialized medicine, you would think that would even it out a little bit. It actually doesn't. It's not as steep as it is in America, but still the wealthiest are the healthiest in those countries too. Okay, just not as steep a gradient. But it's about access, availability, cost, and quality. Okay, and quality of care. Health is, of course, directly related to education, socioeconomic class. The better educated you are, which people who have more money tend to be better educated, the healthier you are. 1, you have the knowledge to make better decisions and healthier decisions. 2, you have better jobs, so you're making more money, and you have insurance, and you have better access to a variety of stuff. And you're accepted in that particular facility. We hear a lot of people in poverty say that they feel like they're not wanted when they go to healthcare facilities, not necessarily local health departments, but when they go to private physicians, into hospitals, that type of thing. They don't feel like they're welcomed, and they don't feel like they are understood. And to a great deal, that's probably true. And also, people who fall into poor health, and they're in middle class and they fall into poor health, they also tend to fall into poverty, which makes sense. It's a situational situation. So you lose your job, you lose your income, you lose your ability to pay your bills, you're going to be in poverty, and therefore you lose that status and your ability and your reason. But because you do a little better in situational poverty because you have resources, and we'll talk about that toward the end. The greater the level of being under-resourced, the less effective our institutions and governments are at achieving better outcomes. It's not like we're not trying to figure this out, okay? Here are the following outcomes that are inextricably linked to poverty across the country. This came out of the Bridges into Healthcare book, and this is not going to be an aha moment for anyone listening to this presentation because we live it in public health. The average age of death is younger for people in poverty. The primary care is often the emergency room. That's changing a little bit with the Affordable Care Act, but not necessarily so. My sister is the manager of an emergency room, and her emergency room visits this year is 300% higher than it was last year, and with people with insurance from the Affordable Care Act and expanded Medicaid. She loves it because she gets more money to do more things, but her client, more and more people in poverty are actually using her emergency room, and I don't know if that's true across the state and across the nation, but she has seen that. Dental visits are fewer, we know that. Everybody would love to have great teeth, but I don't have any money, and the dentist is the last person I'm going to spend my money on, okay? Obesity and diabetes rates are higher because my food choices aren't the highest, I like apples, I like oranges, I like eating good, but I get X amount of money. I don't know who it was too. I think it might have been the Dr. Shepherd or somebody that they said, a woman said to someone to her staff said, I'm not stupid. I know that apples are better for my children than potato chips or than whatever, but I can't afford a bag of apples will feed my family for 2 nights. The cost of a bag of apples, where's my choices? Okay, so there are fewer choices in food because of the income situation. Of course, the rates of cigarette smoking is higher. Access to medical care is less, and mostly due maybe to transportation and to lifestyle issues and to where they've got to get to health care. When we look at generational poverty, as compared, it's a concrete experience. And so when we look at this mental model, and we've spent the last 30 minutes looking at this mental model of poverty, it's an abstract representation of poverty, as I've said. It's not every person in poverty experiences everything in that mental model. And also there are things that in your community can say, well, she didn't even talk about this, and that's in our community. And so, it's a mental model, and it's going to be specific to communities where things are there and things aren't. But there's an interlocking nature to the elements in poverty, and that's why relationships become so important. And it's a depiction of the trap that people in poverty have. There's no future story. There's no choice. There's no power. And maybe there is, but they just don't see it because of living in the tyranny of the moment and living in that survival mode. If you're planning to get out of poverty, it's a tremendous amount of work, and there's not that many people that's going to take that effort that the girl in Adams, Pennsylvania took. That was a lot of work, to get that done and to provide for a family and not to say I'm in poverty anymore. And it's a decision that a lot of our clients are not going to make, okay? And I want to tell you a story to show how interlocking it is when we talk about that tyranny of the moment, okay? There was a woman, she was a single woman, she had 3 children, okay? She works 2 jobs, and so on her way from one job to the other one afternoon, she was running late because she got late out of her first job late. She runs a yellow light and gets pulled over and gets a ticket. because of her busy life, because of the fact that she has no money, she just kind of kept paying that ticket off on her back. Then one that she didn't want to, she just never had the money to get it done, and she forgot about it. 3 months later, she gets pulled over for a broken taillight. Well, we know what happens. She didn't pay her ticket. The police officer hauls her to jail. Okay, because she's put in jail, her kids are taken away and put into foster care. Okay, and then eventually go into a family member's home. Okay, she loses her jobs, both of her jobs, because she got put in jail and she can't go to her jobs. Okay, it takes her over a year to resolve the issue of running through a yellow light. Would that have happened in middle class? Probably not. Okay, because we don't live in that period of the moment. Okay. And so the more resources you have, probably the better, okay? But people in poverty have a hard time, okay? The time horizon of the day, they can't see that future story that we see so well in middle class. We are all about the future story. We want our kids to do better than we did. We want our kids to have more money than we have. We want our kids to have a better life than we had. Our parents wanted the same thing for us. Okay, and don't think people in poverty don't want that for their children. It's just that because of that fear of that moment, that living in survival mode, they can't see that future story. And our biggest job as healthcare providers and as people who work with people in poverty is to help people in poverty see that future story and see how obtainable it is and help them get there. So let's look, we have to look at our mental model too. This is a mental model of middle class. Okay, we could add some stuff to it. We're all about, I'll run around the circle in case you can't see it. We're about shopping, at least this middle class person is, okay? We all have hobbies and sports. Transportation is not a big issue. We all drive cars that are probably less than 5 years old. We have, unless we're into the frugal mode, okay? We all have a big network of family and friends, just like people in poverty usually do, or may not, but a lot of them do, okay? Clubs and civic groups and volunteering we do. We have better health and a lot better access to health. Chemical dependency is still there, but we have more resources. And if we don't utilize those resources and we continue with the chemical dependency issue, then we end up in situational poverty. Okay? Mental health, we either get treatment or we kind of deal with, it's not as bad a mental health, and we're able to sustain ourselves in society. We do political action. We're all about prevention. And I hope everyone in this room, we live prevention. Education's huge to us because we see a future story and we want to get ahead. We have better housing. We have retirement. People in poverty don't have they don't worry about a 401k. Okay. Most of them may not even know what a 401k is because they just want their money for today. That's all they're going to try and get by is today. We're in careers, not jobs. Okay. And our debt is different. It's just we manage our debt better. Child care is different. We're in children's activities where we go after school and we complain all day long about, I got 3 practices to go to today. So this is kind of the middle model. We're all about achievement. Okay. Our relationships are mostly outside of our family are mostly to get us ahead, not get us by. Where relationships are a dependent thing in people in poverty to try and survive where they're at. We still interact with social services, schools, police, and church. I talked about that with the model of poverty, but it's a totally different view than it is for people in poverty because all papers, all everything is ran on the middle class scale. The middle class determines how the world works, and that's because we're the dominant culture. The dominant culture of anything determines who they make the rules. Okay, the dominant culture makes the rules. Does everybody agree with that? For instance, how many people in here are left-handed? This happens all the time. One person in here is left-handed. Tell me something in this world that you have to adjust because you're left-handed and then we live in a right-handed world.
Spiral notebooks.
Spiral notebooks.
Hate them. The ones on the side, because you can't Like the spirals over here, so you can't write right there. Like your writing's all squished up on the
I've
left.
not heard that one. Water fountains, buttons on the right. Mouse, it's always on the right.
Mine's moved.
Good for you. Right-handed is a dominant hand, so everything, you just think about that as you go through the day. Everything is right-handed.
I feel bad for me.
Race, although we've gotten a whole lot better. Look, just in this room alone, we have one African-American lady, okay, one. And she can tell us that white is the dominant culture. And we can say all we want to that it's not, but would you agree that white is the dominant culture? Makes a difference. You know, I was reading the new book that's out is Bridges into Health and Healthcare. And the University of Boston did a study. But what they were looking for is to see if patients in poverty in hospitals across Boston got poorer care than patients not in poverty. And what was astounding to them is they didn't. But patients who were African American, no matter what their economic level, got poorer care than patients who were Caucasian. And that was an aside, an aha moment for them, because they didn't expect to find that, and they didn't expect that to come out so loud and strong in their study. And there's been evidently other studies done to support that. And so I think that that's something that we need to take a look at. But it's true that the dominant culture makes the rules, and in this case, middle class makes the rules. So all our forms are in middle class. All our language is in middle class. And so when people in poverty come in, usually they hear wah, 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 because it's not their culture. And we don't do anything to bridge that between middle class and poverty. Okay? Our businesses, we have shopping malls. Do we find pawn shops right next to the big Fayette County Mall? Probably not. Okay? If they are, they're kind of uppity pawn shops, okay? We don't see payday lenders in our middle class and upper middle class neighborhoods. We have bookstores and banks and Starbucks. How many Starbucks have we ever seen in inner city Louisville? Right down there in the west end of Louisville. Do we see any Starbucks down there? Probably not, okay? Because we have coffee shops and we have nice restaurants. Not just fast food. We love fast food too. There's some same. We have golf courses. How many goes to a golf course in the ghetto? Okay, it's a different. Our businesses are different. And then quickly we'll look at wealth. Wealth has got. There's a growing divide between the rich and the super rich because a lot of the upper middle class have become rich, but have not become super rich. And the super rich do not approve of the rich, by the way, okay? They look at them as, beneath them. They're all about charitable activities, media and political linkages, travel, events, you can look around that, keeping up, because it's all about connections. So in poverty, it's about relationships. Middle class, it's about achievement and that future story. People in wealth don't need to see that future story. They've got that future story. In fact, they kind of depend more on tradition, because they want to keep that legacy going, okay? New money usually isn't accepted. You're not wealth until your money second, third generation, kind of like generational poverty. Then they'll accept you in generational wealth after it's 2 or 3 generations of wealth, okay? New wealth is not accepted, okay? Everything's about connections, who you know, okay, in wealth. Sure, I've told you everything I want you to know about that. Notice that stability, time horizons, and problem-solving strategies and power and wealth. So stability, the environment in poverty is unstable. Would you all agree? Okay. So people have to focus on solving immediate, concrete problems. The environment in middle class is more stable because people have today covered, so we worry about the future. We got today. Okay, so we worry about the future. The environment in wealth is stable, so people don't worry about today or tomorrow. They make sure it keeps going, okay? Focus of time in poverty is the present. They just want to get by today. For middle class, it's about 2 to 4 years. We look about 2 to 4 years out, except for our children, we look about anywhere from 8 to 18 years out, depending on how old they are. But we make plans 2 to 4 years in advance for most of our stuff, okay? And we see that through, and as we do that and we get halfway through the mark, we start moving. So we move ourselves about 2 to 4 years. Wealth is 2 decades. They look to see what will be happening in 20 years, okay? Problem solving. People in poverty have personal power, strength, and fighting ability, but they may not have the power to stop bad things from happening in their neighborhood or community. That's where that relationship piece really comes in. Okay? People in middle class have power of the institutions because we run the institutions. We're the middle class, and we are the institutions, and we make the norms. People in wealth have the power to influence and shape policy and the direction of the community and to create sustainable communities. And so what's really frustrating is when people in wealth, they're 2 middle models away from people in poverty, and they're reluctant to hear a speech like this. They don't want to know about people in poverty. That's not where they are. They're about connections and going to the future. They don't even accept new money, okay? So, and there are policymakers. Just saying. So that's a problem, and a problem that there's not huge solutions for, okay? All right, so we've got our mental models down. Let's talk about hidden rules. Hidden rules are unspoken cues and habits of a group. They come from environment in which one was raised, okay? A child will learn the rules of survival in his or her environment simply by breathing. None of us learned the hidden rules. Mom didn't put up a flip chart and say, okay, here's the rules of the house. Here's what we'll do, okay? If you ever want to see a cute example of this, Google Ann Pittman doing hidden rules on YouTube. It's hilarious because she's hilarious anyway. And so she talked about 2 boys who were fighting in the play yard, and the boys come in and they're all huffed up, and she said boys get huffed up when they're mad. And she said, well, he called me a name, and my mama said if somebody ever calls me a name, I have a right to hit them. That's a hidden rule, right? Well, she can't break that. She's not going to say, well, you can't. Instead, she tells him she's going to take him to, she said, okay. And he said, well, and my mama said if anybody ever hits me, I can hit them back. That's a hidden rule, okay? Not that it's bad or good. And she said, she said, well, where's your mama now? And he said, well, she's at work. She said, well, okay, let's go get in the car. You can fight this out in front of her. And I'm like, oh, no, because we don't go to mama at work. That's another hidden rule, okay? And we could sit here, if we were in that all-day class, we would really tear apart what some of our hidden rules. Hidden rules here at work. Somebody shout out a hidden rule here at work.
Don't burn candles.
Don't burn candles.
Scent.
Don't wear heavy perfume.
Yeah.
Okay? Yeah, there's all kinds of hidden rules, and we can talk about it. Or we don't have time, or we would, and it's a good thing to talk about. I want you to go over them, though, and talk about a few of these. They're easily broken when you don't know them. And you know, when you break a hidden rule, you immediately know you've broken it when you go into someone's home or a certain situation. You go into that, and you know what happens. You get the look. And we give the look. You know, did you see what they wore? Go to church, go to a different church that you're used to going to, or have never been to church in your life, and you go into a church, do you know the rules? When to stand up, when to sit down, when to kneel? Okay? No, and did everybody look at you like, and you only wore like shorts and a tank top. You didn't know you had to wear something special to go to church, or, you know, you went to there's hidden rules, okay? And if we don't know them, then we're going to break them. Well, why do we not expect our people in poverty when they come into our facility and they don't know our hidden rules, or they start a new job, and they don't know you've got to be on time, and that you've got to have reliable transportation, and that you can't just leave just because your children are sick. You know, they don't know the hidden rules, and how can they follow them? Okay? And so we're really bad. We don't want training by our hidden rules. They need to learn it by, baptism by fire. Okay? And so just jump on in. Okay? But if we can teach hidden rules to each other, we do that when we orient people to a new job, right? We teach them their hidden rules when we go into a situation. Then we resolve conflicts and we resolve problems. and we start acting more respectful toward each other. Okay, it's really important. I'm going to Eastern Kentucky tomorrow, and somebody was saying, well, make sure you dress down, because they don't like government people down there. You know, that's a hidden rule. You know, don't be, be careful when you're walking into a restaurant. Don't look too hoity-toity. Don't, There are hidden rules in everywhere you go. And they change by community. There's a lot of standard hidden rules, okay? But each situation has their own hidden rules, okay? And again, the biggest problem is that they're never articulated. Very rarely are they articulated. And also that we equate them to intelligence. Somebody comes in and they do something they break a hidden rule. What's the first thing we say? Well, they're stupid. Okay? Is that necessarily true? No, they said there's a hidden rule. And they say the same thing to us with that look, like, well, you're, one of those things, two light bulbs short of a pack or whatever. Yeah, So I'm going to give you a couple examples of some hidden rules. And when you do the all-day training, there's about 15 that we go through, but I'm going to go through some of the fun ones. Possessions. People in poverty, possessions are people. We've talked a little bit about that. It's definitely a matriarchal system. Mama makes the rules, or grandma, whoever the head matriarch is. You got a son or a grandson that gets thrown into jail because he was drinking and driving, okay? Well, she's really mad at the police for putting him in jail, and she'll go down for the 50th time and bail him out. She's going to bring him home and give him a lashing. I don't care if he is 30 years old, that he's never had before, and he's going to have to beg for forgiveness from Mama. Okay? Now, she won't say that to the police. She's going to that's my child. I'll take care of business. Okay? Very matriarchal society. They own people. If you're going to be accepted in their community, then they want to feel like you're connected. Okay? Middle class, our possessions are things. We all got things. Okay? We got cars and houses and TVs and people and children, and we've got fine stuff or not so fine stuff, things. Wealth, it's one-of-a-kind objects, legacies, pedigrees. You never go into a house of wealth and say, wow, that looks like a Picasso. Well, duh, they would be very offended. Of course that's a real Picasso, because they only buy the finest, okay? It would be the same thing like saying to a middle-class girl, say, oh, what a beautiful engagement ring. That looks like it's a real diamond. We would be offended, wouldn't we? Same deal, okay? So because we're about things, okay, and wealth is about, and then poverty. There are things. I mean, how many times we see people at Walmart that buy things that are poverty and take them back the next week to get something else, or they're always in the exchange line, okay? And so they're about people. So I'll tell you the story really quick. There was this happened when they were first doing Bridges. Bridges Out of Poverty originally was a program that they got this from. They decided to make this because of education. They were seeing the break between educational systems, administration, schools, being in the middle class world, and then not being effective educating their kids in poverty. Well, there's this. Actually, it's outside of Chillicothe, Ohio. There was a family. They loved them. The kids came to school most of the time. They dirt poor. They didn't have anything, and they didn't have a refrigerator. And the kids were talking about it and how they couldn't, to go get meat every day, or just go to the store and stuff. And so the school loved this family, and so they got together and raised their money and bought them a refrigerator. Took it to them. They were so excited about giving this family a refrigerator. They've been living out of coolers with ice for months. Okay. Well, the next week, the kids weren't in school the whole entire week. And so they thought, and they went by the house, nobody was there. They didn't know what had happened. So the next week they came back, and little Bobby they said, what happened? What happened? She said, well, we were so excited about that new refrigerator, we went ahead and sold it and went down and saw Grandma down in Eastern Kentucky, because she's sick and she's dying. And she said, and we're so happy. Thank you so much for giving us that refrigerator so we could go see Grandma. Because we would not have been able to go see Grandma if we wouldn't be able to sell that refrigerator and go down there. And we got to spend a whole week with her, and she's dying. We don't think she'll live past this week. And so thank you so much. Well, the staff were appalled. My gosh, we raised $700 and bought them that gorgeous refrigerator. And now they're still living. But was that important to the people? No, people were important. And otherwise, they weren't going to be able to see Granny before she died. Okay? Because it was a different, we're about things. And they were about people. Okay? Time. Poverty, we've gone through this, it's about now. Okay? And they live in the moment. We're about future, and the wealth is about tradition. Food, love this one. I love food. Okay? It's all about quantity. Do you have enough? Okay, it's very important. You go to a cookout for someone that lives in poverty or who is middle class and raised in poverty. My mama was raised in poverty in the Depression. When you left, first of all, you couldn't eat all the food that was on that table. Okay, and you went home with a plate. Okay, and if you didn't go home with a plate, you were pretty offended that you didn't have enough food to take you a plate home or a little Tupperware bowl or something home of food. Okay, it's all about quantity. Did you get enough? You sure you don't want another? You sure you don't want to go back again? I mean, we got plenty of food here. It's all about quantity. Middle class, we got plenty. Okay, so we're about quality. Did you like it? Was this a good recipe? Should I try this recipe again? Do you think that should I change it? We're all about quality. Wasn't that good stuff? I got this recipe from Paula Deen. You know, and we're all about quality. Well, it's about presentation. Okay, was it presented well? Did it look very aesthetic and very unique? Because they've got quantity and they've got quality, so now it's about presentation. Terry DeRussy Smith tells a story that she and her husband, he was in some company where he dealt with wealthy people. She said he wasn't wealthy, but she said, so we were invited to this man's estate, and she said, I was so excited. And we were going to this dinner. She said, well, my mom always taught me when I went to a dinner, I took a dish. So she's going to this wealthy family's dinner, and she took a casserole. She said, well, I got to the door and immediately knew I blew that hidden rule because the maid looked at me like, what is this? She said, well, it's a casserole. I wanted to contribute to the dinner. She said, we had that fine, beautiful dinner. I never saw that casserole or that dish again because that was a big faux pas. She had totally messed up on that situation. So that's about food. And I have to tell you that, and again, to me, that shows how much growing up in poverty and those middle models kind of move you into middle class too. My parents grew up in poverty. We always had more food than was enough, and probably why I'm obese, because you had to eat till you were full, and because they didn't want you hungry. You know, do you have enough? Language. We're going to spend some time on this. In poverty is a casual register, and language is about survival. Formal register, and it's the language of negotiation. And we live in this room, all over this ITV, in formal language. Wealth is the formal register, but it's about networking. Okay, so let's spend a little time in language because it's important. Of course, if you remember from school, there's 5 different form registers. There's the frozen register, which is the same, like wedding vows, the Lord's Prayer, medical terms. Okay. The frozen language. The formal register is the standard sentence syntax and word choice of the work in school. It has completed sentences. It's specific. It is, and it's not. There's nothing casual about it. Consultative is the formal register when used in conversation. It's not quite as direct as formal register. It's kind of a little bit of a shift into casual, but not much. Casual register is a language between friends and is characterized with just 400 to 800 word vocabulary. Word choice generally is not specific. Conversation is dependent on nonverbal cues. People in poverty use casual register, and they are huge into nonverbal cues. Okay, sentence syntax is often incomplete. We're going to see a little example of that in a minute. Of course, intimate language is the language between lovers or twins. A lot of that hidden, I know what you're talking about. And then it's also the language of sexual harassment. Just thrown in there. So here's some examples. So in casual register, you might say, what's up? And we would say, well, how are you doing? Okay. And you know, if you mess up, you say, my bad. And then people in formal language would say, it's my fault, excuse me. I accept my error and my grievous error. I apologize for my faux pas. We're very formal, okay? I made a mistake. I'm grown can mean anything because it's going to all depend on your body language. I don't wish to comply with your request. Would you consider an alternative? When we're here and when we use casual register in this building, do we get either the look or kind of, you might want to rethink how you wrote that? Absolutely, because I'm bad about casual register. My teens use casual register. And on top of this should be the language of teenagers in my world, because teenagers have their own language that fits into casual register. And you will not understand some of their words and what they mean. And so if you're not smart, if you're smart, you'll ask them what it means, okay? Because they have their own language. But it's all in casual register. But yeah, it's all, casual register always goes with what the body language is, okay? Before we say that, I want to read you this story. This comes out of Bridges Out of Health. Anybody who's ever worked, this is a hospital scenario. Here's an example. This man is in his 20s. He comes into the emergency room with a broken leg. The healthcare provider, how'd this happen? The patient, well, Carl's been working on that car of his forever, and he had it up on the cinder blocks. A skunk got underneath the car and had babies there. Well, the dogs didn't like that one bit. They was going crazy, so I got my gun and went to get that skunk. And the patient's relative says, I told Carl he shouldn't put the car there. That raccoon has been hanging around those houses. That one they left and trashed the place before they moved out? Well, that raccoon took up living there, and it was one busy raccoon. Had babies more than once. And then a skunk decided to live there, too, and that came across a lot to have babies, and they had that baby in the car, those babies in the car. So the health worker, who's a little exasperated, says, so how did your leg get hurt? And he says, I'm trying to tell you. The patient relative says, you got to know that Johnny ain't the most coordinated person alive. I told him he shouldn't be handling that gun while he was under the car. Did the car fall on your leg? The healthcare worker says. The patient says, well, I crawled on a nail first and got it in my arm, and then my cousin Ronnie came over. Was the nail rusty? The patient said, how the hell would I know? I saw that nail. If I saw that nail, I wouldn't have crawled on it. I didn't know Carl had boards on those cinder blocks, and Ronnie's as big as a horse, and he eats like one too. So when I crawled on that nail, I took a painkiller that Ronnie gave me. Healthcare says, how long ago did you take the painkiller, and what was it? I don't know, something Ronnie had. I don't know what it was, but it worked pretty quick. Then I got dizzy and lost my balance. About that time, the skunk did his number on Ronnie, and that made Ronnie mad, and Ronnie mad ain't a pretty sight. Yeah, the relative says. Once Ronnie got mad, and he picked up a cinder block and threw it 20 feet into a window of the neighbor's house. The neighbor didn't bother him no more. At this point, the healthcare professional gives up trying to find out how the guy broke his leg and just writes that the car fell on the man and then he broke his leg. He didn't know, okay? That's a casual conversation. People in poverty are storytellers. How many have experienced this with patients? I know you out there are raising your hands. I can't see you for the PowerPoint. But and when I stop you and say, well, that's nice, but tell me the story. I mean, I need to know the facts, just the facts, ma'am, or sir, that breaks relationship because that's not how they tell their history. Okay, very frustrating. But when we stop them, then we just told them, I don't respect you. I don't want to hear what you've got to say, and you're worthless to me. Now, because if we're telling a story, now here's how it's told by someone in the formal register. Same story. There was a car in the neighborhood on cinder blocks, and the skunk got underneath the car. The dogs were trying to get to the skunk. Johnny brought out a gun to shoot the skunk and crawled onto a nail, injuring his arm. Johnny's friend Ronnie gave him a painkiller, which made him dizzy, and he fell down next to the car. Then the skunk sprayed Ronnie, which made Ronnie mad. Ronnie then picked up one end of the car so the dogs could go after the skunk. But in trying to watch the dogs, he dropped the car. The car didn't fall back on the cinder blocks. It fell on Johnny's leg and broke it. Well, yeah. But at least we know what all that language was before with Ronnie. And we've all been there, but we have to be real. And we understand, all of us understand, that it's frustrating, especially as a middle-class person. But that's important to someone who's a storyteller. And they need to get that's how they need to tell their story. Or meanwhile, you respect them. So now I'm going to tell you how to take care of your leg. I'm going to tell you what I'm going to do to you. But we've broken our relationship completely. So I'm not going to listen as well as I would have if you would have listened to my story, okay, and respected me. I'm not going to take that insulin as a diabetic patient, because you don't really care about me. You're just trying to get me out of your way, okay? So that's what it's really about. An interesting thing is that the number of words that people in welfare are exposed to is about 13 million words, 1 for every 2 prohibitions. I'll explain that in a second. Working class, 26 million words, and professional children are exposed to about 45 million words before they enter kindergarten. I don't mean they're 45 million different words, but they're spoke to that much. Okay, and here's an example. When a child gets up on the couch and is looking out the window, okay, the parent in probably middle class and even in upper class look at the child and they say, well, what do you see on that? What do you see out that window? Is that a bird? Is that bird what's that bird doing? Oh, yeah, he's gotten the worm. What's he going to do with that worm? He's going to feed it to the bird. And then the worm, what will happen to the worm? Well, he'll be ate up. Okay, well, let's get down off the couch. Okay? Well, because in poverty, not that I don't care about my child climbs up on the couch and he's about to fall and hurt himself, but I got 6 other kids running around that I'm responsible for, and I'm trying to cook dinner. What am I going to say? Get down off the couch before you fall. So there were, 7 words to 50 words by someone else who said, hey, let's make this a teachable moment, okay, in middle class, in the working class, and the professional class. And so therefore, on the average, children in poverty typically enter kindergarten 2 years behind their peers. How do they make up those 20 million words when they get to kindergarten? And so therefore, we see that kids in poverty tend to are held back more often kindergarten, first grade, traditionally, because they didn't get that start up, okay? And it's not that the person in poverty didn't care about their children. It's just that they live in crisis mode 24/7, and so it's the tyranny of the moment, okay? So how can we, one of the things people in Bridges say, how can we talk to our people about encouraging, if HANDS people are listening, how do we encourage our parents to nurture that positive talk? And I know that our HANDS program is doing that because I've done this presentation in some of the local health departments, and I know my HANDS people give me feedback. We spend a lot of time with our parents talking about that and talking about that positive talk and spending more time in talk. So that's really one thing our state is doing to improve the future story of our poverty people. So let's finish up. I'm going to get done a little early, aren't I?
You guys 11:30.
I probably got about 15 more minutes. Okay. Let's talk about resources. I've kind of mentioned them all along through here because it is all about resources. Am I someone who's isolated and alone, or am I living around every family member? We may all be in poverty, but we're supporting each other, okay? And other resources. So to better understand poverty, Ruby Payne said that we need to say people in poverty are functioning to the extent to which they do or do without resources, okay? Here are the resources. The first, there's 8 that they identified, and then at the end you're going to see that they identified 3 more. Of course, financial resources, okay? If we had financial resources, we wouldn't be in poverty. So it's kind of a given that if you don't have financial resources. So how do our people in poverty get financial resources? They take advantage of agency time, and they spend a lot of time in agencies getting their food stamps and any other benefits they have, their medical card, all that kind of stuff, because that's how they're sustaining life and meeting their ADLs, okay? That's their financial stability. Or they're out selling drugs to make their money to buy their stuff, okay? Emotional stability is being able to choose and control emotional responses, particularly to negative situations, without engaging in self-destructive behavior. It shows itself through choices. So emotional responses, who do we have to have poor emotional responses? Mental health problems, people with mental health deficiencies, people with drug addictions and alcohol addictions, people who continue to stay in domestic violence homes. Hello, where am I that's my financial support. Okay, and they don't see a way out of that. Okay, and so emotional resources are important. Mental resources, having the mental abilities and acquired skills, reading, writing, computing to deal with daily life. Because I didn't spend a lot of time in school because for whatever reason, or because I have mental health issues. I may not have the acquired skills to survive in a real world. Okay. Spiritual, believe it or not, believing in divine purpose and guidance is an important resource for people to have. It builds resiliency. I heard a post-traumatic stress disorder seminar a few months ago, and the man who gave it said that it was interesting to note that when you map post-traumatic stress disorder from military families, people coming home from across the seas, that when you look through the South, there's much less post-traumatic stress disorder through the Bible Belt than there is anywhere else in the nation, because a spiritual resource builds resiliency to stress and situations. I thought that was interesting. Physical, having physical health and mobility, that's a given. Support systems, having friends, family, and backup resources available to access in times of need. If our girl who ran the yellow light could have called somebody immediately, either to help her pay the ticket or those months later when she went to jail to get the kids and take care of them so they didn't end up in foster care. Those resources are important. Uncle Ray, to get instead of AAA, to get my car and somebody to get me to the health department and my agency time appointments, okay? They're important, and if they don't have that support system. What's interesting is people in generational poverty tend to have better support systems than people in situational poverty, which makes sense, okay? Relationships and role models. How frequent do adults have appropriate nurturing people who are helping them make good decisions and mentoring them and helping them not to engage in destructive behavior? It's really important. And so it's not just about not having money that puts you into poverty. And knowledge of hidden rules. How well do you know the hidden rules? I finally got a job. I'm working at a hospital or a factory. But, my car broke down, so I'm just going to call in every day. Is that acceptable? Or do I know the rule that you're not allowed to call in? Okay, so that's really important that we teach our hidden rules. So what's really interesting is that after they started, Bridges has been around for about 15 or 20 years at least, okay? And so they have a program for people in poverty called Getting Ahead in a Getting By World, and it is a curriculum that community centers use, and people who are wanting to get out of poverty or to better themselves, they go through this curriculum through community programs. And so when they first started this program, and they were in it twice in two or three centers, the Getting Ahead, Getting Well, the people in poverty said there's more resources than those 8. And so 3 more resources have been added. Integrity and trust. People in poverty say, your word is good. Do what you say. You will do. Because if not, we don't feel any safer than we do in our own environment. Okay, so they depend on people to do what they're going to say. Okay, motivation and persistence. You have the energy and drive to prepare for, plan, and complete projects, jobs, and personal changes. If you don't have the motivation to get yourself out of poverty and improve your life, that's across the continuum. That doesn't matter what financial class you're in. Okay, if I don't have the motivation to lose weight, am I going to lose weight? Trust me, it hasn't happened. I have motivation and persistence. So those are important. If I have the motivation to get something done, I'm going to do it, right? And so that's a resource that our people need. And they need the formal register. If the only thing I've ever spoke my whole life is casual register, how am I going to learn formal register unless someone teaches it to me? And so these folks in poverty came and said, I don't know how to speak formal register. So how am I going to do in a job interview? Probably not real well, okay? So these are 3 other resources that we have. Does anybody have any comments about this? So what we ask, there are several, this one doesn't include the last 3. But what we would do if I did an all-day training, or if you took this back and decided to think about incorporating a Bridges type framework into your work and to examine your work and see where you can make differences with your people in poverty and making changes and influencing helping your people in poverty see a future story, then this resource sheet looks really good. You know, everybody's different. Our clients are different. Think about a client right now that you've taken care of today, in the last week, month, year. Someone in poverty, maybe a family member, in poverty. Think about them. On a scale of 1 to 5, what is their financial resources? Even like a situational poverty, what's their financial resources? What are their emotional coping strategies? What are their mental capabilities? Is it a 5? I'm just very poor and I don't have physical support. I don't have housing. What is their spiritual capability? Are they in church? Do they have a group? Do they have a group that they meet with? Whatever that is. What is their physical capabilities on a scale of 1 to 5? Support systems, role models, their knowledge of hidden rules, and you can even look at their integrity and trust, their motivation and persistence, and their informal register. Where are they on these things? Because if that way you see that person as an individual, well, they're doing great on 4 areas, but here's something I can really work with them on and say, hey, we need to get you doing X, okay? People in poverty are problem solvers. They live in crisis 24/7. They're probably much better problem solvers than most of us. They're always in crisis. There's always drama. And so helping them to see where they need to problem solve and to get themselves into that future story and how to get themselves a little bit more out of that here in the moment is beneficial. Now, you're going to not walk up to them and say, I really think that your biggest problem is that you have emotional coping strategies problems, okay? And we're going to work on those. No, you're going to say, hey, how are you doing with, when is it that you want to take a drink? Well, and there's a lot of programs doing this, well, okay, so how are we going to get you away from that? And we've done this kind of work. This is our work. This is what we do. But this is a good assessment tool for our clients to say, if we do every client say, we're just going to get you benefits to help you financially, and, whatever. Where's the role model? That's where Big Brothers and Big Sisters comes in with teenagers and young children, because people need role models. Many of our teenagers, state that they do not have someone trusted in their life they can talk to about serious problems. And so there are adults out there with the same problem. Many of us may say, if we live in an isolated life, I don't have anybody, finding them. And so this is an assessment tool to see where they are, to see what they're doing, and to see where you can help them get and see their future story. In the school world and in adolescent health, positive youth development role models, where we're teaching our teens about being confident by having goals, by giving back to their community, and how to help them succeed and to see their future story, and to see how they're going to be a successful adult, and that they don't have to live in this cycle anymore. And I think that that's really important, and I think there are adults that we can do that with too. And I know this sounds really altruistic, but this really is a good tool. The real voyage of discovery consists not in seeking new landscapes, but in having new eyes. And I think that's really true, that we've got to see our clients, our people we engage with in a different way if we're going to make a difference. And this will affect us not only with that individual, with population health. So I'm available for staff trainings. This has been, I'm not kidding, as you all know, a whirlwind of information that can really be spread out. There's so much more that can be done in an all-day training, and some real good hands-on tools that you could be taught. I'll be glad to come and do a training. And actually, a training to a specific community or group is so much better, because doing a broad training, there's just too many different communities coming together to make plans, and that way you could plan together to make something that's specific to your health department, your community. 2 resources that are out is the Bridges Out of Poverty book, and the Bridges into Healthcare just came out in the last several months. In fact, I'll be going to a training on that in the spring, and will become a certified Bridges into Healthcare training. What that took was Terry Trucy Smith and 2 nurses, actually, took the information from Bridges Out of Poverty and applied it to the healthcare world. And it's really good, and it's the same stuff. There's no new stuff. It's just applied to the healthcare setting, but it's really a good book to read, and it's got some good case studies in there where you can really see what happens when you apply the Bridges framework to that. So, Ms. Joy, I'm 30 minutes early. Okay, thank you all for listening to me for the last hour and a half, and contact me. There's my contact information. I appreciate it so much.
Thank you, Benita. Appreciate your time and effort and energy and sharing that knowledge with us. I've had some great takeaways. Thank you. Okay. We'll go ahead and I'll use this opportunity to share some announcements. We do have several announcements to share with you, both from the nursing office and from various divisions in DPH. First and most importantly, I wanted to remind everybody that it's nursing licensure renewal time. The deadline is midnight of Halloween, October 31st. Please be sure to go ahead and get your license renewed and get that verification back that you do have a valid license through October 31st of 2015. For those of you all who are nurse leaders, please go ahead and not wait until the afternoon of October 31st to check to make sure that everybody has their license renewed, because they and to make sure that the people perhaps who work off site with your agency in home health, or they might be on maternity leave, or they may be out on vacation, you want to go ahead and check on those and make sure that those are verified and you have that that verification in your hand and in their personnel file. If a nurse does work without having a valid license, if she comes to work that next Monday and does not have a valid and up-to-date license, we will have to, that agency will have to report that to the Kentucky Board of Nursing, because you cannot work as a nurse without a valid license. So go ahead and save yourself and the nurse and your agency that time and trouble, and be proactive and confirm and verify the active licensure status of all of your RNs. Are there any questions about that?
I
Joanne?
have a question. I want to know why they stopped sending a card for us to carry.
Mm-hmm.
I mean, it's you know, it's making the assumption that you have the ability to show that you're a nurse everywhere you go, but you do not have that anymore, unless you have access to a computer.
Mm-hmm.
Is there a reason that they stopped sending cards?
Joanne's question was why KBN stopped providing a nurse a license to all of us to be able to provide that documentation. I don't know the reason. I've always assumed it had to do with something with cost, just, you know, as far as producing that card and mailing it out to everybody, but I don't know that for certain. But there's a validation function on the KBN website, but you're right, unless you're around a laptop or a cell phone at the time, there's really no way, and especially if you don't have that nurse's license number, there's no way to validate that. It's all online now.
And you know, a lot of things, especially when you talk about places like the Red River Gorge and the MRC operations that they had at this last, you know, event. I mean, there was very little communication once you get up to that part of the world. And if people would come along and you would want to be able to identify them, there's just nothing there to do that. I mean, it'd be different if we had something on our driver's license or some way to identify the way that, yes, you are a nurse or you're not. But, you know, if you talk to anyone at that level, I wouldn't care to pay the extra
Yeah.
and
Okay.
have it mailed.
Sure.
But I really would feel better if I have something I could carry with me
Hard copy, yeah.
that, you know.
Okay. Thanks for your input.
Plastic card, I have
a plastic card
from like 4 or 5 years ago
Right.
before, and then they didn't.
Like AAA and just send you.
And the discussion here in the room, so for you all, is that the last plastic card that we received as nurses still shows that we're a nurse, but it doesn't have the expiration date on there. Yeah, yeah.
One thing you can do is, just like we printed our validation for you all, for whoever, you can make a copy of that, even shrink it a little bit on our copier and just fold it up and carry it in your wallet.
Yeah, and
so
that's-
you're valid to
that's in
October
fact-
15.
That's what I do, and so that may be something that you might want to do, Joanne, is once you get that validation, print that off and put it in your wallet or whatever. Okay, any other questions about licensure renewal? Okay. April 15th and October 15th are two big important days in the Kentucky Women's Cancer Screening Program world. That is the deadline date, as you all know as well, for our minimum data elements, submission to the CDC. So Rom hit the submit button yesterday afternoon, and for the 17th consecutive time, the program met all 11 of their quality core indicators. So I wanted to thank everyone in the room and, of course, everybody out in the field, because that achievement could not be possible without each and every one of you all. For those of y'all who enroll the clients, who provide the direct services for the clients, who provide case management for those women. It does take everybody across the state and that individualized quality care, and so that's an astounding accomplishment. And so I wanted to thank each of you. I'll let you know the status of that submission, and congratulations to each of you all on that achievement. Next, I wanted to let you know that Sandy Clark, who was previously our well child and school health nurse consultant, yesterday was her last day with DPH. She transferred to the Kentucky Board of Nursing, and so she's going to be working with the CARE program there. And so in the interim, if you have technical assistance questions or needs regarding well child trainings or school health questions, please contact Shelley Adams, who is the branch manager in maternal and child health over those programs. And Shelley will be glad to assist you with any issues or questions that you may have. Shelley's email, just so you'll know, is her first name is SHELLEY.Adams@ky.gov. So you won't get her unless you put that E in that second E in her name. She's working on a transition of care, as we say in the nursing world, for a communication plan and a list of contact folks who will be able to help with the coordination and dissemination of information for well child and school health programs. But in the interim, if you'll go ahead and contact Shelley, she'll be glad to assist you. And then she said once that transition plan is finalized, she'll be sure to let everybody know that. So we'll miss Sandy. She's been here. She worked in DPH for almost 8 years. And so our loss is KBN's gain. Wanted to also mention that the diabetes program, Teresa Wren asked me to mention and advertise their upcoming diabetes symposium of 2014, which will be held Friday, November 7th at the Marriott East in Louisville. Last year, she said they had over 300 participants, so it's a huge conference. There's national and state presenters. The cost of the conference, registration on or before October 20th is $55, and registration fee after October 20th is $75. So again, that conference is Friday, November 7th at the Marriott East in Louisville, and the symposium is held in recognition of World Diabetes Day. and there will be CEs provided for CDEs, registered dietitians, registered nurses, and registered pharmacists. So if you have any questions or interest in attending this conference, let me know, and I can, route you to Teresa, or you can contact Teresa or the diabetes team directly. Next, I wanted to share, I had received some questions, and the request was to share the updates on these topics at the PHNITV, so I'm happy to do that. There were questions about the status of the ICD-10 conversion. As you all may know, that has been at the national level an effort and initiative to convert diagnosis codes from ICD-9 to ICD-10. That deadline has been extended twice, and thank goodness for that. But Cynthia Robinson sent out an email on at the end of September 29th, and she included the nurse leaders and various other local health department contacts. But I wanted to let you all know that Cynthia is the point of contact for ICD-10 conversion matters. That is her, what she's going to be the point of contact for that transition. She is working on developing the list of ICD-9 cost centers to a readable version of the ICD-10 codes. And as soon as that transition, that crosswalk is completed, Cynthia will send that out. So Cynthia Robinson, again, is our point of contact. If you have any other questions about the transition, it's a huge, overwhelming undertaking, but it is going on, and she'll be sure to keep you all in the loop on that. I did have a presenter, Allison Taylor Cox, who is our policy advisor in the commissioner's office. I had invited her to come and speak and answer any questions about the caregiver affidavit. Unfortunately, she had an ill child and was unable to join us this morning. But if you do have, I know we had Janet Overstreet and Allison had a few questions when that information was first revised in the administrative reference. I've not seen any more email traffic about that particular update recently, but certainly if you have questions, feel free to let me know, and I can answer those, help answer those, or route those to Allison or Janet for their input on that matter as well. The EMR update, wanted to share with you all that there's not been a status in the last few months as far as where we are with obtaining an EMR. That what is going on is that there is a RFP that's under development, a request for proposal, which will be sent out from the cabinet level, and the applications to provide that EMR service and that software application will be submitted and go through the usual procurement process. And so I wanted to let you all know, just that's still in progress, still in the works. I don't have a projected implementation date. Of course, that all fits into the time frame with the RFP. So I wanted to let you all know that as well. Any other questions about updates that might be going on, that are going on here at DPH that I may or may not know the update status on? Okay. Anybody from the field? Okay, at this time, I'd like to invite Nancy Hamilton to come up. Nancy is a registered nurse in the immunization program, and she is one of our members of our Nurse Executive Committee. And so one of our goals that we've identified is to provide regular and ongoing updates about the NEC activities through the ITV venue, and also through emails or other opportunities that we have to share our activities. So I invited Nancy to join us today, so she's going to be providing us a brief update. you, Nancy.
No, it's right here.
All right. These updates are what we discussed in the NEC meeting at our August meeting. Joy did speak about some of them, but we did want to give you an update of things that we discussed. The 2014-15 influenza protocols are finished, done, and out. They also went out with the memo, the BIS statements, the VARs. Everything should be out, and the health department should have those. We did talk about the questions concerning ACIP voting on recommending the Prevnar 13 and PPSV 23s. They are being submitted for protocol changes, and you should have those soon. Like that. Let's see. We discussed protocol signatures for emergency protocols for the local health departments and not having a medical staff there, and that possibly they could go through Dr. White office to be signed, and then also have a place for your medical director to sign in your health departments. That's in discussion now to help make that process a little bit easier. We discussed the APRN CAPA-NS law that went into effect in July, and the changes that would occur with that regulation. I think everybody has seen that law. We did update some of our deliverables that we have been working on, and I'd like to read those to you. And then we've also added some new measures to go along with those deliverables. The top one, the number one, is to develop nursing core competencies for public health programs as listed in the administrative reference. And it's almost an ongoing thing that we have to keep updating them and making sure that they are clear and that the local health departments can understand them in the best way to promote that when the person comes in. Also, development and implementation of standardized policies and procedure template for program services in the CCSG guide. Enhancing communication venues with public health nurses to include surveys, public health nursing, video conference updates, emails, and communications. And that's an ongoing discussion for us, and trying to always be on top of how to get the information out to local health departments and the public health. Assess and collect data to target NEC strategies, which is internal survey of NEC memberships, and that we can devise new ways to collect that data and get it out there to you. Committees and work group meetings as needed, and nurse leadership conferences, in which we're hoping to continue those nurse leadership conferences, especially the ones like we had just recently, back in May, I guess, and that was very informative, and hopefully we can consider and make more of those, and maybe have more nurses come or be available in more ways that more nurses could come. The measures that we've decided on are annual CCSG evaluations results as submitted through survey and monkey responses. Survey monkey response, not just a monkey response, a survey monkey response, I should say. That wouldn't be very fun. Alignment with the CCSG QI project and AIM statement to streamline the PHPR document in order to provide clinical guidance for local health department nurses based on core public health services while eliminating any unnecessary program requirements and undue burden on local health department staff. We're going to work on that. Hopefully we'll be able to make things more cohesive for everyone. Competencies presented to local health department nurse leaders for review and feedback on the PHN update ITV in June of 2015. And communication plans monitor number of participants of PHN video conferences, including NEC report at each PHN video conference with invitation to NEC membership to provide the next NEC update. That's what I just did. So there you go. We have done one of the measures today. All right. Any questions? All right. Thank you all.
Thanks, Nancy.
You're welcome.
We do have 13, I believe it is 13 nurse leaders, both from local health departments and the Department for Public Health, on the Nurse Executive Committee. We do have a very a long list of goals and objectives. Our number one goal, as Nancy mentioned, is to work on the nurse competencies for the different programs and work in conjunction with the program leads here at DPH to be able to include in the AR section in those training guidelines and the training guideline chapter, how does a nurse demonstrate competency in a particular program? So, Joanne, perhaps you're a member of our NEC committee. Maybe next in December, maybe you can provide the update for our. No, she's shaking her head no. For the NEC, we have a meeting. We have a meeting on October 28th, and so we'll be working really hard on working on those competencies. I also wanted to share. I wanted to thank the nurse leaders and the local health department directors who are able to allow their APRNs to attend the APRN conference in Bardstown recently. There were approximately 50 local health department APRNs who attended. The agenda was very strong. It included the 5-hour mandatory pharmacology CE offering by Dr. Glenn Farr from the University of Tennessee, and he's always very well received. We had a great day on the second day for. We talked about syphilis, and we talked about how serving the LGBT community. We talked about GYN problems and issues. We had a professor from the University of Kentucky OB-GYN department. So it was very heavy laden on the clinical issues that particularly the women's health APRNs would see in their daily practice. So they were very pleased, and I think they really were engaged in the conversation. So thank you to all of you all who supported your APRNs attending that conference. Ellen, she helped with the CEs as always, and then several of the women's health staff helped me as well to get that all pulled together. So it takes a village to pull off a meeting like that. So I hope that your APRNs came back enthusiastic and excited about the information that they learned and share and incorporate into their practice. Okay. Are there any, Doug has 3 minutes, and if Dr. Thurman's not here in 3 minutes, then we'll be, we'll go send out the posse form. Do you have anything? Emily Anderson, you're going to check on him. Okay. Are there any questions or comments or updates, thanks, Em, from the members here in the audience that you would like to share? Any updates from your programs? Silence. Nothing from TB, Maria?
Well, we did have a.
Why don't you come on up here and get in front of the microphone?
Lindsay, you chime in.
Maria Dalby with the TB program, nurse consultant with the TB program. There you go.
Hi there.
I don't like putting you on the spot.
That's all right. It's okay. We recently had a corrections training October the 2nd, and it was very well received. We had our Southeastern National Tuberculosis Center come from Florida to come up and do our training, and we had about 30-ish so participants. But the key players that we needed there were there, and they took home some new messages. Our success with our genotyping with CDC has finally made it to the next hurdle, and our lab was able to send things back to CDC. That was kind of on hold there for a little bit. We're continuing to have success with the Gene Expert with our rapid testing to look for tuberculosis in 2 hours. I'm trying to think what other trainings we have coming up.
We're doing training for this year, but
We're going to have our 101s in the next, May? All our new nurses, all you new nurses out there that are new to TB, will be reach out to Lindsay Pappas whenever you need your new training. Probably sometime in May. We usually have one in the spring and one in the fall.
I'm
depending on funding. Trying to think of anything else updated in TV.
Maria,
Mm-hmm.
you had a save the date for some type of a clinical tuberculosis.
We did the advanced, like we had in 2010. We've not been able to offer that. Time and funding has just kind of caught up with us, and so we had to, Lindsay had to send out a cancellation this past week. So hopefully next year we can reach out to those of you who had TB experiences and bring your lessons learned to our advanced clinical next year. So if you're having some good examples, reach out to us, and we'll be happy to get those down and reach back to you guys sometime when we have that in the summer. We usually get it like around November or so. Good question, Joanne. I'm just trying to think. Yeah, that was scheduled for November 3rd, and it was canceled. Anything else? No?
Thank you. Thanks, Maria. Melody, do you have anything from KWCSP or perinatal Hep B or immunization program? I'm not going to call names. I'll just call programs. No? Okay. Okay. What, do you all have any questions for me from the field? Dr. Thurman's on his way up. Just talk, just mention your name, Dr. Thurman.
Hope it was good.
It was. We're all ready for you. We are ready. We are live. We're on camera.
Okay.
Yeah.
Did you get my slides?
I got your slides.
All right.
We did send out the slides this morning, first thing this morning, in two different sets. So if you didn't have the opportunity to download those before you joined the ITV, they will be waiting in your mailbox when you return. This presentation was approved for 1.2 nursing CEs as well as 1 hour of ERT hours. So if you do want to claim ERT hours for this session, please make sure that you submit the attendance verification form, which I sent out with the presentation, with Dr. Thurman's presentation, and submit that to TJ Sugg.
So are we going to project the slides?
Yes, yes, we are. We're going to get those.
That would be good.
If you all will bear with me just a moment, we're going to get Dr. Thurman set up here. What about that? Are you impressed?
I'm impressed.
Yeah, okay.
So can these guys see it anyway?
Yeah, yes, they can. I've got to work on this when I sit down.
Okay.
Okay. Next, I'd like to introduce Doug Thurman, Captain Doug Thurman. Dr. Thurman is a CDC Career Epidemiology Field Officer with the Kentucky Department for Public Health. He also recently, and he's going to talk a lot about that, provided his services in Liberia for the Ebola outbreak, and so we want to thank Dr. Thurman for his service. And Doug is an excellent speaker. He's a wonderful friend, and if you don't know Dr. Thurman, or if you've not had the opportunity to hear him speak, you're in for a real treat. So what I'll do, and he's laughing at me, so then what I'm going to do, I'm going to go back and figure out how to use this clicker.
Okay.
And then here's your mouse right here, and I'm going to go ahead and I'll have you on the camera first of all, and then we'll put your presentation on, okay?
Great, thanks.
All righty.
Well, hello, everybody. I think I've been outdone by my introduction, so if I don't live up to it, I'm going to be in big trouble. But it's nice to have you all here. How many of you have already heard the Ebola talk I did in someplace else? It's Lindsay. Okay, good. So out in ITV land, I would bet most of you haven't seen this because you've not gone to, unless you went to the APRN meeting. I did it there. So if you did it there, you can zone out and just take the CEUs for free, or CNEs. So anyway, so yeah, so I'm stationed here in Kentucky. I'm a CDC federal officer, and I have been here since 2002, and now I'm currently serving as the Deputy State Epidemiologist and the Assistant Division Director for the Division of Epidemiology and Health Planning. But as a federal assignee for CDC, I get the opportunity sometimes to go deploy and do exciting, fun things like go to Ebola land, or in 2010 I went to Nigeria for a acute lead poisoning outbreak there, and I responded to Hurricane Katrina. So I get to see more of the world sometimes than the average person. And so when they made a call for people to go to Liberia, I was actually a Peace Corps volunteer in Liberia in 1998 to 1990. And did I say 98? 1988 to 1990. Went backwards. So the call went out to a returned Peace Corps volunteer listserv at CDC. They were asking for anyone who'd been in Peace Corps, or especially who'd been to West Africa, and that's where exactly I'd been for Peace Corps, and had been working on a health project when I was there, so it all kind of fit together. So I asked my wife permission, and she actually encouraged me, and I asked my boss, Dr. Humbaugh, and he was surprisingly encouraging. And I said yesterday maybe he was trying to get rid of me, but anyway. So then I went to CDC and I said, well, I'd be willing to consider doing this, and boy, they were excited because they were looking for people rapidly to get out there. This was back in very end of July or very beginning of August. I can't remember when I first talked to them, but the week that I went ahead and agreed to go was the week that Dr. Brantley got sick and Nancy Wrightball got sick, and the head Sierra Leonean doctor died of Ebola. And so after that, it was a little scarier to think about going because it was actually affecting more people. And so, but everyone was still encouraging, and I went ahead and got signed up, and I deployed on August. I think I left on the 10th from here and spent a day in Atlanta, and left on the 11th and got there on the 12th of August, and I came back on I left September 8th and got back here on the 10th in the States. So what I'm going to talk about today is the Ebola virus outbreak and what's gone on there, and kind of some of the things that are happening here. Just kind of mix it all up so you can get a little bit of everything. So I hope everyone can see the slides now, and we'll go on. I just want to assure the people in the room, there's my temperature log. I've been more than 21 days out, and I never got a fever, and I didn't fly during that time, so we should be okay. So we have objectives, which I think were put out there before, right, Joy, for the CNE. So I won't go over those because we only have an hour, right? So I want to speed through this. I did this talk at the Advanced Practice Registered Nurse Conference, and I've added some slides since then. So I had to take out some other slides to try and fit it together. So this is the first time I'm doing this one. So if I get lost, please forgive me. So Ebola, just to give you a little bit of Ebola virus history, it was first recognized in 1976, and there were actually two outbreaks. One was in the Ebola River Valley in Zaire, which is now the Democratic Republic of Congo, DRC, and that went from September to October in 1976, and there were 318 cases and 280 deaths for an 88% mortality rate, and that's what Ebola was named after, was that particular outbreak, because it was near this Ebola River. But there was another outbreak that actually started earlier and went later in Sudan, and that had 284 cases, 151 deaths, so it only had 53% mortality. And they both popped up the same year, and that's the first time we've ever identified Ebola. And so those two strains, Ebola Zaire and Ebola Sudan, were named for those two outbreaks. And since that time, there's just been sporadic outbreaks until through 2013, and they've all been in sub-Saharan Africa and East or Central Africa only, as far as human outbreaks. And the mortality rate's been anywhere from 25% to 90%. Now, just yesterday, I got back a presentation for clearance at CDC, and they took out rates out of everything. So I guess mortality was 25% to 90%, not the mortality rate. I'm not quite sure what the difference is on that, but anyway, from 1976 to 2013, I went to the World Health Organization site and counted up, and I counted 23 outbreaks in humans, and only 7 of those had more than 100 cases, and the range was from 1 case to 425. So there's kind of been these smaller scale, although 425 people dying is a lot of people. They're not, thousands of people. Until now, and so this is the first time we've had Ebola in West Africa, and it's the first time Ebola has reached capital cities. It's never been in bigger cities. It's always been out in the bush up to this point. This particular outbreak in West Africa has encompassed all these other outbreaks. It has more cases than all previous outbreaks combined. At this point, Guinea, Sierra Leone, Liberia, Nigeria, and Senegal are all involved in this one outbreak. As of September, and it hasn't gone any further than that right now, other than the United States, and Spain has had a couple of folks who came there from these other countries and brought the disease with them. There is the unrelated outbreak in Democratic Republic of Congo. It's still going on, but it's still out in the bush area, and it's fairly contained. So it's not the same strain as this one. It's a different strain, so it's not involved in this particular West African outbreak. So to talk about Ebola virus, it's a filovirus, and there's 2 types, Marburg and Ebola, that are in that genus, and 5 subtypes, Zaire, Sudan, Thai forest, Bundibugyo, and Reston. And of course, Zaire and Sudan were named after those first 2 outbreaks, and a couple more came along, and Reston only affects non-human primates. I think humans can get infected, but they don't have any symptoms. They don't get any symptomology. The Zaire and Sudan strains cause the most severe illness, and they have higher case fatality rates, so they tend to be more deadly. And the West African outbreak right now is caused by the Zaire strain. So here's a current map of where the outbreak is occurring. You see the orange is where there's active cases, the red is new active areas, and the yellow is areas that were active that are not active now, so that means they haven't had a case in like 21 days. And you can see there's quite a large area. Most of Liberia, almost all of Sierra Leone, and then parts of Guinea are involved. Now, Cote d'Ivoire, the Ivory Coast, right off to the east there, I'm shocked that they haven't gotten involved yet, because when I was in Liberia, we had our first cases in the far eastern counties of Liberia, down there at the very bottom of the picture, those orange places. And those are right on the border with Ivory Coast. You see above, Guinea has cases in that area too. So why it hasn't crossed the border, I don't know. These countries have very, very porous borders. It's kind of like our border with Mexico. They've got roads through that they can block, but there's jungle all around. And people, if they come up to the border and they see there's border guards, they just hike off in the jungle and go around and come out the other side. You know, so there's not a lot of ways to stop people from crossing back and forth. And a lot of people do that. That's very common there to move between the countries. So I pulled these numbers off last night. So at this point, unfortunately, and TJ Sugg, if any of you know him, he found this graph on the World Health Organization website somewhere completely filled out. It was on the CDC website completely filled out earlier, and now the version up there they don't have this version. They just have overall numbers, so I have to pull them off and stick them in here. But I couldn't find the other one. I got to bug TJ and find out where he found that. But anyway, the totals, I just circled the stuff down at the bottom. So right now we have a total of almost 9,000 cases in that West African outbreak, of which just about half are deaths. It's 49.9%. That had actually been up at 57, 58%, then it dropped down to around 47. Now we're back up to almost 50%. And about 5,000 of those are confirmed, so a little more than half of those are actually lab-confirmed cases. So there's a lot of folks that have died that were never confirmed. And I will just add a note to that. There's kind of 2 sides to that story. There's a lot of folks that have died with Ebola that were never counted either, so these numbers are probably low, because this outbreak was happening for quite a while before anybody had any kind of surveillance going, so a lot of bodies were being buried, and a lot of death was happening that nobody was counting at all. So not only was it not lab confirmed, it wasn't even counted. On the other hand, there's a lot of death that's being counted as Ebola that's not Ebola, because people are afraid there now, and so when someone dies, they don't want to touch the body, and they call the burial team, and if that happens, that body's counted as Ebola. So I gave this story earlier with the APRN conference. You know, so my last day there, I had to walk from our hotel to the UNICEF office, which is just a couple blocks away. And as I was walking with our CDC team, there were 6 of us. A bunch of librarians were there at a house, and they were out on the road trying to get our attention. So I stopped and talked to them, and my team kept walking along down the road, and so it's probably a mistake. But having been in Liberia and been familiar with Liberian English, I heard what they were saying. I wanted to find out what was going on, and so they asked us. They were asking for help, and they wanted to know who we were. And I said we were CDC, and then they said, well, can you help us? And I said, oh, I don't know. What's the problem? They said the burial team can't come. And I said, what do you mean? You have a body here? And the guy pointed to the ground about 4 feet away from me, and there was a blanket over a body, which I hadn't even seen until he showed me, because it was behind a little curb at the porch of this house. He said, we called yesterday and no one's come. And so I said, well, we're CDC. We don't pick up bodies, but I'll talk to the burial team and see if we can do that. So when I got to the Ministry of Health later that day, I did do that. And that was my last day there. I actually flew out that night. And they did respond and get that body picked up. But later in the day, I was with an embassy driver, and the U.S. Embassy is very near to there. And he had heard the story was that this woman was pregnant, and they were afraid to go to the hospital because of Ebola, and so she was delivering at home, and she had a breech to deliver, and she died in childbirth. So she probably did not have Ebola, but that would have been counted as an Ebola death, because the burial team would have gone out to pick her up. So I don't think those extraneous deaths that are not Ebola balance out for all the deaths that are Ebola that weren't counted. So I still think these counts are far underestimates of what's really going on. But there's two sides to that story. So where does Ebola come from? So Ebola lives mainly in bats. They're the host organism, and it doesn't kill bats. They can live with it and carry it around. But it is also found in monkeys and gorillas and duikers, and it makes them very sick, and a lot of them die. So often you'll see a monkey or gorilla die off in an area before the humans get affected, because the humans are getting it from the dead animals, or from the animals that are sick. So, and I just added this other slide, which is a big stock CDC slide, just for the center picture at the top, although the one down at the bottom with the watermelon is kind of cute too, the bat down there. But look at the one at the top in the middle with the girl holding that bat. Look how big that bat is. So that's why they eat them for food, because they're about the size of a raccoon, you know. So they make a thing called bat soup, or they'll cut them up and cook the meat and things like that, just like any other animal, and that's a source of food in those countries. One of the surviving sources of food, because they've hunted out most of the bush meat. You know, there's not a lot of animals left in those countries. So how do people get infected? Well, now I will say that these slides have some funny terms on them, because these are slides I actually used in Liberia, and I wanted to do them for your benefit to keep them in here. But so pee-pee and poo-poo and things like that are not what we normally say here in the United States, but that's what we use there. So the first way people got infected in these countries is bushmeat. Catching an infected animal, preparing the animal to eat or for the skin, eating the bushmeat if it's not cooked enough. If they touch the spit or the pee-pee or the poo-poo or the blood of the animal, all that can carry Ebola, because when an animal is sick with Ebola, it's viremic. It's through all their body fluids, so they can get it in any way. And so if you can imagine catching a bat, you know, and catching it to eat, what do they have to do to it? Well, they have to slaughter it, right? They got to cut it open, take the organs out, take the skin off, all that kind of stuff. What's going to happen when you do that? You're going to get blood and body fluids all over your hands. Okay, so that's great, but it probably wouldn't infect the person unless they had little cuts in their hands, which is very possible. If they're cutting up the animal and stuff, they could get cuts in their hands and get blood in that and get infected that way. But even if they didn't get infected that way, these people aren't in rural America at a farm where they go wash their hands afterwards. Either they don't wash their hands, or they wash it with leaves, or find some water nearby and get off some of the stuff with their hands. But they're not using soap and water and hand sanitizer and all that kind of stuff. So the likelihood of them getting infected if the animal they slaughtered has Ebola is pretty sure. You know, so fortunately, not most bats aren't flying around with Ebola all the time, just like rabies here. A few have it, most don't. So you aren't likely to get infected that way, but it's possible, and that's why we see these Ebola outbreaks just coming up every once in a while. So if they eat with their hands afterwards and they've got stuff on their fingers still, they can infect themselves. If there's small cuts in their skin, if the meat's not cooked well, if they splash body fluid in their eyes or in their mouth while they're cutting it up, which is highly likely, you know, they're going to get infected if the animal has Ebola. So that's how it gets into the human population. That's how we think every outbreak has happened in Africa, is people eating bushmeat, and then they get infected, and then it starts passing person to person, which is the second way. How do people get infected? Person to person. And that's what's happening now in those countries. There's no more bushmeat causing the outbreak. There's people passing it from one person to another. So same thing, touching body fluids of a person with Ebola. Now, semen is an unusual one there, breast milk. That's been shown. One woman got infected by her husband who had recovered from Ebola, and it was 7 weeks after he'd recovered, and she got infected with Ebola from the semen. And so they've shown that to actually be possible. But you're not, the idea of touching semen isn't necessarily going to transmit it, but having sexual intercourse. And the important point here is that the person can be alive or dead that's transmitting the disease. They don't have to be alive to transmit it. They can be dead. So there's, of course, touching or sharing of bedding, blankets, sheets, eating utensils, clothing, other items used by that person. If you touch that stuff fairly soon after the person has touched it, and if they've gotten body fluids on it of some sort, it's probably infectious. But an important point is that they can only pass the virus after they have symptoms. So if someone's exposed, that doesn't mean they're infectious. They're not going to be infectious until they have symptoms. And we've seen that play out a little bit recently with the Thomas Duncan episode. So when he flew from Africa, he had no symptoms. So they didn't worry about the people on those flights. Now this nurse that was just identified, she took a flight and her fever had just started. So they're identifying all the people who were on the flight that she was with to follow them up to make sure they don't get symptoms. I don't think they're going to see anybody that way, because when you first start having symptoms, you're not very infectious, and she probably wasn't like putting body fluid on people on the plane or anything, so it's probably not likely that anyone got infected. But if someone did on that plane, that's going to be a real game changer. You know, if that would say, gosh, you can be infectious earlier, or you could possibly have some airborne transmission. So we'll see what happens with all that. Yeah, it is scary. Somebody in the room said it's scary. So risk factors for infection right now are residence in or travel to an area where Ebola virus disease transmission is active. So that's West Africa. Direct contact with blood or body fluids of a patient suspected to have Ebola virus disease. So actually being in contact with somebody, taking care of them, cleaning up their vomit, you know, things like that is a very high risk. Direct handling of bats, rodents, and or primates from disease endemic areas. Now, so someone asked me today, well, what if it gets in the bats here in the United States? Well, I don't think it's gonna, first of all. Second of all, because I'm not sure how it would get from us to bats. But second of all, if it is in the bats, what are we gonna do? We're not out there slaughtering bats to eat usually, so I don't think it's gonna get into people, you know, in any easy fashion, even if that did happen. Now, people are worried about dogs too. Of course, they euthanized the dog of the first patient, and they've got one that's in quarantine now from the second nurse. So we'll see how they handle that. But I thought it was silly they euthanized that dog because I thought that would be a great dog to keep on hand to see if they develop symptoms or have any antibodies or things like that. But they got rid of it. So of course, handling of a deceased person suspected of having Ebola virus disease in preparation for funeral rituals is a big deal, and in those cultures. Now, that's not so much happening now because people have been so bombarded with messages about not handling dead bodies that they call the burial teams for anyone who dies because they're afraid they might have Ebola. So it's not as much of a risk. But if you can imagine, if you have a loved one and they've got Ebola and they're staying at your home because you couldn't get them in a treatment, you know, which we'll talk about in a little bit, you're probably going to get exposed somewhere in there. But if they die, do you want their body just to sit there in the house? Well, probably not. You probably want to move it outside because sometimes it'll take 4 or 5 days for the burial team to show up. Well, so there you've got to handle the body or somehow get it picked up on sheets or something and move it out of the house. Or if you leave it in the house, you've got the risk of it being there, you know, and people touching it or doing something. But the funeral rituals, it's very common in those cultures too. When someone dies, they don't have funeral homes that come pick up the body and haul them off and embalm them. They take their clothes off, they wash the body down, and then they dress them in nice clothes, and then they have a funeral, and everybody comes and hugs and kisses the body. And so it's a huge, huge risk for Ebola because at that point, that body's very infectious, and it will stay infectious for a while, and we'll talk about that in a minute. Poor prognostic indicators. So there's several things that can indicate you don't have a good chance of survival. Pregnancy is one. If you're pregnant and you get Ebola, it's likely to be more virulent with you. If there's hemorrhaging starting, if you're under 5 years of age, and CDC just told me on my presentation I sent for clearance that if you're over 44, that's also shown to be a risk. So under 5 and over 44. And then if your symptoms are progressing really rapidly, of course, that's a bad sign, and if the person goes into shock, so there's things that happen. So this brings into question, you know, one of the big important issues. Now, you guys are public health nurses, so you're not generally going to be working in the hospitals, the ERs where they're treating people, but one of the big questions is how much treatment do we give someone? What they did with Thomas Duncan, which I think led to the risk that these nurses got infected, was they had him intubated, they did dialysis, they had IVs in him. Those are all decisions the hospital has to make, whether they're going to go down that route. You know, if someone's to the point where they're having breathing difficulty with Ebola, it sounds harsh, but I don't think they're probably going to live anyway. So if you're going to take the measure of intubating them, you're putting a lot of people at risk for something that's probably not going to work. You know, so the hospitals have to make those decisions how far they want to go. And I'm not a clinician, so I'm not advocating anything. I'll just say that in my disclaimer. You know, but those are tough decisions because when you're doing intubation, you got to change that every day. You get lots of saliva and goop on the tubes. You know, it's very hard to deal with that, to deal with those fluids without the risk of getting somebody else infected. So, and I think that may be what happened with the Duncan case. So what are symptoms of Ebola? So it starts with fever, headache, muscle, joint pain, fatigue, and weakness. What do those sound like? Flu. Here in Africa, they sound like malaria. You know, so it's just like a lot of other illnesses, the starting symptoms. You can't tell what it is. But then, as time goes on, you might get vomiting or you know, this is one of my Liberian slides. Runny stomach is what they call it. They said diarrhea, running stomach. So, and you see our Liberian pictures. Those kind of pictures are all over in Africa for, you know, for regular diarrheal diseases and things like that. You know, to show people the things we're talking about, because a lot of people are illiterate. So, if you have pain in your stomach, if you got anorexia, you're not hungry, red eyes, cough or trouble breathing, or finally bleeding from the nose or gums or in your vomit or in your diarrhea. Those are all possibilities of indicating Ebola. Yes, ma'am, Joy.
Is there any progression of those symptoms, particularly the sudden onset? I mean, do most cases start out with a fever?
Yes.
Okay, so then do they go on to it,
Yeah.
they progress to a headache or?
Well, mostly they'll start off with those first four. So they'll have fever to start with, probably have a headache, maybe some muscle joint pain. It just depends on the person what exact symptoms they get. A small percent, like maybe 5 to 10%, don't get a fever, but almost everybody does. So it's a pretty good sign if they've got a fever and then they move on. So after 1 to 2 days, now I've got this slide I need to change because there's some things on here that I don't think are right. But see, the typical course is 14 to 21 days, but you initially have that fever, headache, muscle pain, and fatigue. Now your nausea and vomiting are down that list. Those usually come after 1 to 2 days. So that starts a little bit later on in the course, and losing your appetite, things like that. There are some other less common symptoms. You can have a sore throat, and could have chest pain, hiccups, which is kind of funny because it's always been on the CDC list of symptoms. That generally only happens just before they die, so it's not something that you would diagnose someone with hiccups as having Ebola. So you have to be aware of that. That's why I put on the near end of life. Shortness of breath, trouble swallowing, those are all things for more advanced stages. And then, of course, you may get a maculopapular rash, other hemorrhaging, which I think I've got a couple pictures of here. The early symptoms may be similar to malaria, dengue, tropical fevers, that kind of stuff. So there's a lot of other things that it could be. So it makes it difficult to know what to do when you have someone walk in, and we're experiencing that here in the United States. You guys are not aware of this yet, but you soon will be because we're referring them to the local health departments. We're getting a ton of calls from hospitals asking about patients they've got, if they should be. Most of them are isolated already. We've already isolated the patient. We've got them on negative pressure air and all this other stuff. And everyone so far has had absolutely no risk of Ebola. So the two I've taken this morning was someone who traveled from Serbia through Brussels to Atlanta to Lexington or something, and so they had them isolated because they had a fever and they were worried they had Ebola. And then the other one was, what was the other one? Oh, now I'm forgetting. I've had two this morning. John Poe's had about 4 this morning. So we're just getting massive numbers of calls about people, and it's the nice thing is they're easy to deal with because the only risk is if you've been to West Africa or you were with someone with Ebola, like in Texas, if you flew up from there or something. There's no other risk. If you've been back for more than 21 days, or if you went to West Africa some other time, that's not a risk. It's only if you've been to those countries within that period of time, 21 days. So anyway, it's going to be an interesting road to follow for the next few weeks because I think a lot of people are going to be asked those questions. Here's some pictures. I don't like the picture of the guy with his eye. I don't think you can really see the hemorrhage there. He's getting bloodshot eyes. But you can see that on that arm there. So you can get severe bleeding, blood clotting. But one thing that's really important in this Ebola outbreak particularly, we're only seeing hemorrhaging in about 50% of cases who die. We're not seeing it in 50% of cases total. It's about 50% of cases who die. So they can have, hemorrhaging happening anywhere. You can be coughing up blood. It could be coming out of your ear. It could be coming out of your mouth, your nose. It could be in your stool, in your vomit. So that's an indication that it's some kind of hemorrhagic fever. Whether it's Ebola or Lassa fever or something. But that's a good sign that you know what you've got, even if you haven't tested it yet. So how long until someone gets sick after being exposed to Ebola? So after exposure, symptoms come between 2 and 21 days. It's usually about 1 to 2 weeks. So we expect people to get sick, like Tom Frieden's been saying, the director of CDC, 8 to 10 days is the highest range where people usually get sick. But they can get sick earlier. They can get sick later than that. But if there's no symptoms 21 days after exposure, so the person, say for instance, I was in Liberia, when I came home I had to take my temperature for 21 days. After that, there's no risk of Ebola because I've gotten past the incubation period. So that's why that question is so critical. If people come in, even at the health department, and say, yeah, I just came from Sierra Leone, and you say, well, how long ago? They said, well, it was in July. Well, okay, they're not at risk anymore. They've been back more than 21 days, so you don't have to worry about that. You have to worry about whatever their symptoms are, being flu or something else, And we have had several cases of people come with malaria that were tested here in the U.S. They thought they might have Ebola, and they tested positive for malaria. So that's definitely a risk. And malaria is a lot more common in those countries than Ebola is, even though Ebola is in a rampant epidemic right now. So again, a person infected with Ebola can only give this virus to someone else if they have symptoms of illness. So they're not going to infect anyone else. Like flu, you can get it like the day before your symptoms start, things like that. It's not that way with Ebola. When your symptoms start, that's when you start becoming infectious, and it grows over time. So fatal Ebola virus, it's about 25 to 90% mortality rate in the different outbreaks that have happened so far. But the important thing is that the virus quantity increases until death, like I just said. So as the person gets sicker, they're getting more and more viremic. And patients who've died of Ebola virus are highly infectious. Their body is highly infectious, okay? And it can even pass through sweat. So if they've been sweating as they went through the final process of death, they can have that on the outside of their body. Okay, so it commonly occurs 7 to 10 days after symptom onset for death, and it can remain body. This was, and I don't know, this is one of the questions I got on the review of my slides at CDC. They said, where did you learn this from? Or how do you document this, the 5 to 6 weeks that the body can be infectious? I don't know where I got that from, but it was when I was in Liberia, and I was with several Ebola experts, and somebody told me it can be infectious for 5 to 6 weeks. That may have even been on a slide that I got from someone in Liberia. I don't know, but anyway, so I've changed that on my new slide set to an extended period instead of 5 to 6 weeks. But they told me it was 5 to 6 weeks. The body can stay infectious, so a very, very long time. So and that's a key point. It's not just bodies, but body fluids. So Ebola is a fairly fragile virus, and this was a confusing point for the Liberians because they were told it was a weak virus, and so they're asking questions, well, what's a weak virus? Why is it a weak virus? It kills so many people. It's not a weak virus. And I think what they were referring to is people saying it's kind of fragile. It doesn't live in the environment very well. If it gets too cold, it gets too hot, it gets water on it, air can kill it. All these different things can kill Ebola virus. So it's not stable like some other viruses that'll stay, like hepatitis B will stay on the surface for 3 weeks and things like that. It's not going to be like that. But it will stay active in body fluids and things where it's got a substance to be in for a very long time. So if it's in vomit or feces, diarrhea, if it's in a body, it'll stay active for a long time. So that's and most of those things it's only a couple days, 3 days, but with the body it can be quite long. So it's very, very dangerous because the body's the most viremic and it's the most infectious. So that's part of the reason that this has spread so far in West Africa is people handling the bodies after the person has died. So how do we know if it's Ebola? Of course, that's the big question. And even people coming here to the United States, because they could have malaria, they could have typhoid, they could even have cholera. There's many other illnesses that it could be. And that was the issue in West Africa because, and that's why a lot of healthcare workers got infected because they're used to seeing all these other illnesses, and then people were coming in with Ebola and it had the same symptoms as the other, so they treat them for those symptoms and not realize they were getting infected with Ebola at the same time. As I said before, not all people with Ebola have bleeding, so you can't guarantee that the person doesn't have Ebola if they don't have bleeding. And you can't test. Now, it's not that you can't test for Ebola until 3 days after symptoms start, but the test isn't reliable. So if I test someone, and they've been doing this down in Texas, if I test someone on day 2 and they come up negative, I can't say that they don't have Ebola. They may just not have had a high enough viral load to detect yet. But if they get a positive, then I do know they have it, even if it's early. But you have to get to day 3, 72 hours after symptoms start, to be sure that the positive, the negative is really a negative. So we recommend. I mean, they're doing it now. They're testing people immediately, like that sheriff's deputy that went out. But they said he was negative, so I'm surprised because that wouldn't have been reliable for another day or two after, unless his symptoms started earlier than we heard. So the bottom line is you have to act as if the person has Ebola if they've got the risk factors. Now, that's the confusion that's happening in Kentucky right now. All these health departments are calling and saying, I've got a guy who traveled internationally, he's got a fever. Who cares? If he doesn't have the risk factors, if he didn't go to West Africa or wasn't around an Ebola patient, he's not at risk for Ebola. And that's the question this morning about this person from Serbia. She said, well, we just thought it was a low risk. We wanted to verify with you it was a low risk. And I said, it's a no risk. There's no risk this person has Ebola. Even if you think they could have gotten on a flight on a plane, there would have had to be someone who was sick actively on that flight to infect that person. And they wouldn't have gotten sick by now, having just come back yesterday or day before, whatever. It would take more time than that to get infected, to get symptoms. So that's the big key is do they have those risk factors? If they do, then you have to ring all the bells and whistles and treat the person like they've got Ebola until they're tested, and you know they don't. Okay, so prevention and control. So the cornerstone of Ebola outbreak control worldwide is, I'm not in trouble, am I? Sorry, our legal person just walked in. So the cornerstone of Ebola outbreak control is to isolate cases as soon as possible so that they can't infect other people. And once you do that, you need to identify all the people that they were in contact with, and then isolate them if they become symptomatic so they can't infect other people. So that's what we've done throughout history since 1976 with every Ebola outbreak is isolate the cases and then track their contacts. In West Africa, that whole process has spiraled out of control because there's just too many people. So the first issue was it wasn't possible to keep isolating all the cases because there's not enough Ebola treatment units. There weren't enough beds. Now they're working on that, and it takes time. And one of the big issues is you can build all the treatment units you want. They're usually tents with a wooden floor, and they've got a bunch of mattresses on the floor, and the people lay in there, and that's where they are taken care of, fed and given water and rehydration fluids and things like that. But when I got there, there was only JFK Hospital had a treatment unit with, I think, 25 or 35 beds. Doctors Without Borders had a treatment unit with, I think, 40 beds. This is in Monrovia. And there was a treatment unit up in Lofa County in far north in Liberia, and it had probably 30 beds or something like that. That was for the whole country of like 4 million people, and we already had hundreds and hundreds of cases. So what was happening at that time was people were coming to the treatment units if they were brave enough to do it, because most people were scared. They thought they were going to get Ebola if they went there, and they thought they would just go there and die. So a lot of people just didn't even go. But the people that did go, a lot of them were turned away, or they were left outside, and they would die on the ground outside the treatment unit because there was no beds to take them in and nobody to take them home. And so that was a huge issue. You couldn't isolate the cases very well. People who loved their family members and didn't want to leave them on the ground would take them back home and have them in their house as they progressed through the illness. So very, very difficult situation. Well, and then in that situation, you can imagine there's lots and lots of contacts for each person because they're at their home, and their friends and family are all coming to see them. They feel bad for them. They're all touching them and stuff. So there's hundreds and hundreds of contacts, and it got to the point that it wasn't feasible when I was there. So that was August to September. They had basically given up on contact tracing. There just wasn't enough workers to go do it. So what they did was they were moving to a model of, and I don't know how that went because I left. They were moving to a model of contacting community leaders in all the small neighborhoods to go to them each day and say, do you know of anyone in your neighborhood that's sick? And if they did find someone, then they would go try and isolate them, and work that way instead of trying to identify all the contacts because it just wasn't feasible at that point. Okay, so control measure barriers. So there's tons of barriers in West Africa to effective control. So as I mentioned, there's not enough Ebola treatment units, the ETUs. Our military is there helping to build one right now. It's going to be 35 beds, and it's going to only treat people who are healthcare workers who've gotten Ebola, so they don't have to transport them to other countries. So they're going to be focused on those. There's some other groups that are trying to add some more Doctors Without Borders, and I'll call them MSF because that's their international name. It's Medicines Sans Frontiers, and it's MSF. They, while I was there, stood up a 140-bed treatment unit on top of the one they already had. So they added another 100 beds, and they had capacity to go up to 400. I don't know if they got that far. But, as I started to say earlier, and I never finished, you can build all these treatment units. You got to have people to staff them. You got to have doctors and nurses. Now, it's primarily nurses like you guys. Doctors tend to only go visit a patient once a day in these treatment units. Nurses, they're the ones who are doing the everyday care all the time, so they're in and out of the treatment unit. But having enough of those is a huge issue because it's very resource intensive. Our military, the U.S. military, when I was there, we were trying to talk them into coming and doing a treatment unit, which they're now doing, which is probably under duress because they refused to do it when we were there. They said it would cost $52 million if they took all their equipment back after it was closed, or $58 million if they left their equipment there for I think it was a 25-bed unit was what they were talking about. So, so I mean, just astronomical costs for them to do it, which was kind of strange because really it's just a tent with a floor and some basic equipment in there. So I don't know why they were talking that kind of price, but maybe just the resources to have the soldiers there to do all the work and transport them there and things like that. So anyway, so that was a huge barrier, huge barrier, because if you don't have the treatment units, then what do you do? What do you tell people? Just keep your loved one at home and let them die and hope not to get infected. I mean, that's kind of the way it was when I got there. And so another big issue was coordination of the activities that were going on. So I was at the Ministry of Health several days while I was there. They were kind of the incident command center, but they didn't have access to all their resources. So the call center was in another place. The burial team was located in another place. The case investigation teams and contact tracing teams were located someplace else. And they have communication with cell phones, but it was a huge issue. The call center would take calls and not be able to, I've got them down as call center resources, another issue there. They didn't have enough people there, so they would either not answer the phone, or when they answered it, they may not know what to say. And indeed, our social mobilization work group that I was in, I wasn't there this day, but they called the call center just to see what response they would get, because what we were working on, I was in a health promotion social mobilization initiative with UNICEF and WHO and UNMIL and stuff. I mean, our job was to try and get messaging out to the people that was effective. Well, on all of our messages, it said call 4455, which is the National Ebola Hotline, and they'll tell you what to do. Well, if you call 4455 and you can't get told what to do and you don't get a response, our messaging is going to get thrown out the window. Nobody's going to care what you're saying because it's not believable. So we wanted to see if that would happen or not. So they called and got a guy, and he couldn't answer any of their questions. I think he was probably getting frustrated. He finally said, well, what you need to do is you need to call the call center. And they said, well, you are the call center. He says, no, I mean, call back, and hopefully you'll get someone who knows the answers. And so, so I mean, that was the kind of the status of there wasn't enough people nor enough qualified people to really answer the questions. And so then the case investigation teams didn't get sent out in a timely fashion. And the contact tracing teams after that didn't get sent out, or there weren't enough of them. So there was this huge backlog of people being investigated. So someone might call with a family member who has Ebola. No one comes to see him for a couple days. So they're like, what do we do? When they finally come, they try and take them to the treatment unit, and there's no bed. So they bring them back home. And then the contact tracing team doesn't show up for a couple more days. So there's, in the meantime, a whole bunch of people have gotten infected. And so it's just huge issues with trying to coordinate all these resources. So one of the guys on my team had started really working to try to structure the incident command system so that they'd have one building to work in where all these different teams are coordinated. So that was a good effort, and I think they finally got that going. Burial teams was the final big barrier. They often didn't have enough vehicles or fuel or personnel. They have to, of course, have PPE and be really trained on it so they don't infect themselves in picking those bodies up. And so often bodies would be left, like I said, anywhere from 2 to 5 days in a home. And so if you can imagine, in your home today, if you had a loved one laying there dead, you really wouldn't want to keep going on with that. You probably want to get them out of there, and yet you're not in the tropics, and you probably have air conditioning, so you've got at least some advantage that they don't have there, and so that was the situation, and it was still going on well after I was there. Wendy Murphy from Tennessee, she's a CFO there, a career RFP field officer like myself, she wrote an email, an update a couple of weeks ago, and she said that she went out with the burial team one day while she was there, and one of the houses they visited, the husband said, well, my wife died 5 days ago, so she'd been there 5 days, in the home without being picked up yet, and so they got her that day. So those kind of things, it's just so many barriers. You're talking about a country, all three of these countries, with very, very low resources and infrastructure, not very much, almost virtually no public health infrastructure. Their healthcare infrastructure pretty much collapsed. It was just coming back online when I was there. What happened was a lot of hospitals closed because their staff died. A lot of people got Ebola and died, so they closed the hospitals. And even if they didn't close them, a lot of healthcare workers quit coming to work because they were scared of getting Ebola, so then they couldn't function. And people wouldn't go to the hospitals because they were scared of getting Ebola because that's where all the sick people are, So when I left, they said 80% of the healthcare facilities were open again, but I visited some, and there was almost no patients. Nobody was coming because they were scared to go. So that's why a lot of people were dying of other conditions than Ebola, because they weren't getting treatment for other stuff that they needed treatment for. So lots and lots of barriers. So the treatment units, just to give you a little insight on those, they're not your typical hospital. Most hospitals there have really stark conditions, and it's something you'd be probably shocked at being nurses, but it's usually just an open room with a cement floor, some open windows. There's very, very little in those rooms. There's usually mattresses on the floor, and if it's an area with mosquitoes, they might have mosquito nets hanging from the ceiling that can cover the mattress so somebody can lay there without mosquitoes biting them. You put a lot of people into one room. When initially there was very limited PPE for the staff, and it wasn't understood well. Most of the staff understood personal protective equipment to be for their protection, not to protect their patients as well. So they would wear the same PPE all day long and go from patient to patient, and saying, I'm doing it right, I've got my gloves on, I've got my apron on, my gown, I'm safe, but they'd be carrying body fluids on those gowns and stuff to each patient, and so not a great situation. And then, like I was saying, they've built temporary structures to handle the Ebola response. These Ebola treatment units are tent cities, basically, with big, gigantic canvas tents, and they have a bunch of people in each tent. And so I'll show a couple pictures of that. So here's one. This is LWA 3, the Ebola treatment unit, and this is run by MSF, the Doctors Without Borders. LWA stands for Eternal Love Wins All, and that was a Christian-based hospital system that was in place when I was back there in Peace Corps, and it's still there now. But they built these treatment units outside the hospital area. And so that line in the middle is a covered area that goes between the sets of tents. There's like 4 tents running on each side of this, and that's where the patients go out. You can see some patients there kind of in the center left that are just sitting there. And so the care they gave in these places was basically just supportive care. They gave them food, rehydration salts, fluids, that kind of stuff. MSF had a policy against doing IVs because of the possibility of needle stick injury, so they didn't get any advanced care. They just basically came to the Ebola treatment unit to be isolated, and then they waited to see if they survived or not. So that was the status of care there. You can see some mattresses leaning up against a fence there on the right. The guys in yellow in the middle, that's Dr. Frieden and a couple other people from our team that suited up and went into the hot area and visited with some patients there. Now, see the orange fence in the foreground, I'm behind that, and I'm in the clean area when I took this picture, and so there's an area where you have to wash your hands with chlorine water and dip the soles of your shoes in chlorine water, and then you come in, and that area is supposed to be clean, and that's where the staff goes into the hot area, and then they come out through cleaning stations, which I will show you here. So on the top picture, you see where they're hanging up stuff to dry. That's like the aprons that guy is wearing. They've been washed with chlorine water and then hung to dry. And you can see there's a washing machine right there and lots of buckets, colorful buckets, and those all have chlorine water and stuff in them to wash things with. In the bottom picture, it's a little, I don't know if I can show you here. Yeah, the mouse is showing up. So right there where the mouse is, that's the hot area in the back, and this is the chute coming out of the hot area. And you see there's a chute there and a chute there and a chute there. There's 3 in this unit here. And then it's fenced off beyond that, so this is the only way in and out of the hot area for the treatment unit. And what they do, you see this container here in the middle, that's full of chlorine water. And so when the person comes out of the hot area, they come into the chute, into here, and you see there's a bucket right there that they dip their feet into to try and clean their boots off to get any body fluids off when they come into that area. And then they come and stand right here, and one of these guys has this backpack on with the chlorine spray pack on, and he's standing where that pink stool is in front of the person who's coming out, and that person stops at the end there, and then he starts giving them instructions exactly what to do, which glove to take off, and what next step is. Every time they take something off, then they wash their hands in chlorine water. You see there's a big bucket right here with a spigot on it. That's a bucket full of chlorine water, a barrel. And so each step they do, he'll say, take your left glove off, now wash your hands. Take your right glove off, now wash your hands. Now pull the strap off the face mask, now wash your hands. Now pull the face mask off, now wash your hands. Now take the goggles off, put it in the bucket, wash your hands. Every step of the way, they're cleaning off over and over and over again, and he's spraying them with chlorine spray every time too, each step that they do to make sure they're trying to kill the virus. And you see there's a hole in the wall right there, if you can see that, and a big barrel. Well, that's where they push out the gowns and stuff after they're done with them, the stuff that's going to be reused, and it goes into a chlorine barrel, and they push it down and get it mixed in the water, and then it goes out and gets washed and then hung to dry. And so each thing, they've got a step for every possible thing so that you don't infect yourself. And it was kind of funny because Dr. Frieden, the head of CDC, was there, and that was the day I was taking these pictures. And I'll show a picture of him in a second. But he was in his press conference later on. He was saying they were yelling at me, and it was because the man was trying to tell him what to do, and he kept doing the wrong thing. And the guys are speaking Liberian English, so he probably didn't understand it very well. And the part where they started yelling at him was these gowns have a flap on the front of them, and you have to open that flap to unzip it. And the guy kept trying to get him to open the flap so he could spray it with chlorine spray, but he kept reaching for the zipper. And the guy kept going, no, 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 you know, and he'd stop, and then he'd say, take the flap. He'd show him by visual how to pull the flap back, and he reached for the zipper again. And so the guy yelled at him again. And so, you know, he'd been in there for over an hour, I think like an hour and a half, and was totally hot and probably wiped out. So he probably wasn't thinking as clearly as he could. So here's a picture of him coming out. So there's Dr. Frieden, the head of CDC, and I just want you to note he is soaked from top down to where his gown was tied there because it's so hot out there with all that PPE on. So then that's the guy. See, he's spraying the bottom of the gown there around his legs. So when you take it off, that last step, and you see he's still got the gloves on his hands, and those have been washed in the chlorine water again. You unzip the thing, and then you have to stick one hand inside the left lapel and shuffle it off your arm and shimmy it off your arm, pull your hand out, and then do the same thing on the right side, and then you kind of do a little hula move and get the thing slip down around your legs so you don't touch it, so you're not touching the outside of it anytime. And then they spray it off again, and he washes his hand again, then they take it off, his legs, and then they spray again, and then he washes his hands, and he finally takes the last gloves off and gets out. So it's a very, very, very comprehensive process. And MSF is very good at this. They're the experts at treating patients and getting out safely. They've had a couple people get infected in the overall response, but they've got hundreds and hundreds of people working there. So the fact that they've only had a couple people infected is a pretty good record. Oh, that's only the first half, Joy. You got the second half?
Yes, I do.
I think so.
How much more time do you think?
3 hours.
Okay.
I can sit through how much time you want.
No, you're good.
Sorry, we're taking a break to switch slides. Yes, Nancy?
I have a question. So they're burying these people, and I don't know if they have rules and regulations about burial procedures like we do over here. But what about runoff water and how do they, you know what I'm asking? How do they?
Yeah, water runoff. So Nancy's asking about burial and runoff water. Runoff water is not so much of a risk because water itself will kill Ebola. So, and what they're washing the bodies with is usually chlorine water. If it was at a funeral and it was just lay people doing it, I would say there'd be a risk immediately from that, but not down the road. So great. But in a lot of cases now they're trying to cremate the bodies rather than bury them, and so the burial team comes and takes the body and takes it off to the crematorium. So. But that's another story in itself because the crematorium broke down while I was there. It could only do 20 bodies a day, and there were far more bodies than there was time to get them through the crematorium. So, because it took a whole bunch of hours to do 20 bodies. It was like 20 hours or something to burn all the bodies. So then they'd start with the next set. And so at one point I was at the MSF Ebola treatment unit talking to a new administrator who'd just come in, and he said that morning they'd had him suit up and go in to help remove bodies, and he said it was a very gruesome task because there was people just sitting in chairs who died in the night, and were just sitting there, and they'd have to remove their bodies. And he said they had 48 bodies that morning and no place to put them, so they had taken them to one side of the treatment unit and kind of laid them all out. But he said that was very demoralizing to all the staff and the patients there, so they finally decided to take them to the crematorium, even though it wasn't working. So they moved all the bodies there and put them behind a wall where they couldn't be seen easily by anybody. So that was so there's just a bunch of bodies stacked up there, and so. This was the entrance. How much time do you want me to take, Joy?
We have till 12:30.
Oh my goodness! And Allison still has to talk.
Well, she just has a couple minutes.
Okay.
Yeah, I'm good.
Okay, I'll go quick. Okay. So.
I'd rather listen to you talk than me.
Yeah.
This was the entrance to the staff entrance to the Ebola treatment unit at JFK Hospital. Now it's a hospital funded by President Kennedy back in the 60s, and you can see that it's not really a welcoming place, and that's where the staff would come in and out. This was inside the clean area of that treatment unit entrance, and these guys were just standing around, but what you don't see, you see the goggles hanging in the back there. Those things here are goggles that are hanging to dry after they've been used. And there's other folks in the same area that, like this guy, who have some PPE on. And when we got in there, we thought it was a holding unit. We found out it was a treatment unit once we talked to this Dr. Ben, who was the guy in charge, and that behind them is the entrance into the treatment unit. So people were coming out, nurses and doctors, with their PPE on, and he's got his apron on. You can't see it there, but there's stuff on his front, like blood and stuff like that. You can't really see it there, and so he's just walking out, and there's people wandering around in that area, all mixing together with PPE, without PPE, and things like that. Just a total infection control nightmare, and so that was our deputy team leader there. We accidentally went in here because we were looking for a holding center and got the treatment unit. And so once we found out it was treatment unit, we asked a few questions and we got out of there. And I didn't touch anything. I was keeping my hands off everything while I was in there. But yeah, just that's the kind of situation and that was run by the Ministry of Health, not by Doctors Without Borders. On the other hand, Firestone, they've got the largest rubber plantation in the world in Liberia. It's about 200 square miles, and they have their own hospital, and they took their outpatient treatment unit, which is this building, they turned it into an Ebola treatment unit. And they put in some extra toilets. They made a suspect, probable, and confirmed ward, and they took the door handles off each side of the door, on one side of each of the doors, so you could only go one way through the unit. You couldn't go from like the confirmed to the probable people and infect other people. You can only go one way through it. So they did some really innovative things. That big orange thing out in front is a storage container, like this on ships, a shipping container. They cut holes in it for windows, put some stools and stuff in it, and they made it into a decon center where the people come out, just like in Doctors Without Borders. They would come out and get cleaned right there before they left the unit. And these people that are standing there are coming out of the dressing room. They go in the room over here on the side and get their gowns and all that stuff on. You can see they're not wearing pappers and full face to head or head to toe garb, and they have had no one infected in their treatment units, even though they have had a number of patients there. They've had They had like 23 people die when I was there. I think it's up to like 76 now or something. But so they've done a smashing job at Firestone of really, and they did this on their own. They got on the internet and they called CDC and asked a lot of questions. They didn't have any PPE, so they started off with chemical hazmat suits, and then they got PPE ordered and got stuff in, and they've done a really good job. And they also set up outside the front, here's a triage station. They took another storage container, cut a couple windows in it, put a wood front on it for doors, and this guy comes out. Anybody coming to the hospital has to go past him. He takes their temperature with a non-touch temperature gauge, asks a whole bunch of questions. If they are suspect for Ebola, they go straight to the treatment unit. If they're not, then they're allowed to go in the hospital and be seen for their regular care. So, and they're one of the few hospitals that stayed open the whole time. They didn't close. But once again, there were very few patients when I was there. The only ward they had was mostly filled was the pregnancy and birthing area. There were a lot of women were there, but otherwise it was pretty empty. There's Dr. Frieden. He's talking to someone who survived. She's in the window there, and he was walking by, and they said, "Oh, there's one of our survivors." He says, "Oh, I got to talk to her." So he stopped and started asking her questions through the window and stuff. So she had gotten through Ebola and was getting ready to get released. Some big barriers there, besides the ones about having enough resources. Illiteracy. About 70% of the population is illiterate. You know, they had a 12-year war that started right when I left in 1990, and so a whole generation of kids has not been educated. And so a lot of people are illiterate. There's a lot of suspicion of government and outsiders, and I just saw a new email about this yesterday that they are working on. There's several villages in northern Liberia, and some of you may have heard of those workers that were killed in Guinea that were out trying to do education. Well, that was the stuff I was working on, was how to do that education in villages. But these people had gone doing that in Guinea, and people had killed them because they suspected they were bringing Ebola to their village. The burial practices, of course, we already talked about, and the socioeconomic situation. It's very crowded. West Point's a slum in Monrovia that was quarantined with barbed wire when cases started popping up there, and they didn't do anything for food and water, and so there was a riot, and a kid got killed, and stuff like that's going on. There's a lot of people per household, and we're talking a one-room household, not your nice 3.5 bath, 2-bedroom, whatever house. It's a mud hut with 8 or 10 people in it. And there's no running water virtually anywhere except Monrovia in this country. And there's not a lot of cleaning materials, although there is often bleach because they like to keep their clothes looking nice, so they have a lot of bleach around. So that's actually a good thing. That's something you can use for the Ebola response. So what I was working on was the health promotion, social mobilization, and that was 2 main efforts, was changing the messaging, because the original message that was going out was Ebola is real, because a lot of people didn't believe it when the outbreak started. Well, by the time I was there, that wasn't so much of an issue, so we were de-emphasizing that and emphasizing how do you protect people at home. Another message was don't eat bushmeat. Well, that wasn't an issue anymore either. It was how do you prevent person-to-person transmission. So how do you get those messages to the people? And so one of the ways we were going to do it was through this general community health volunteer training, which is taking volunteers across the country who would go door to door and actually meet with people and talk to them about Ebola and help them to understand, because there was tons of messaging out there. I have a great new slide that I wasn't able to put in here yet, but tons of billboards, radio messages, but it wasn't sinking in. People weren't really changing behavior, because I don't think they understood what was going on and why they needed to change behavior. So our goal was to get to the person-to-person level and talk to people and help them to understand. And I did that in a couple talks and with radio broadcasters and the hotel staff. There's my radio broadcaster crew. And boy, when you start telling them stuff about Ebola, they eat it up. They were so hungry for information. They asked great questions. They weren't dumb. They understood what you were saying. They wanted to know what they needed to do to prevent it. But when I said don't eat bushmeat, they all laughed, because that's what they eat. I mean, that's how they get their source of protein. So they said, well, what are we supposed to do? Either starve or get Ebola. So there's those issues in countries like this. It's not like you go to your corner Kroger's and buy your meat and stuff and you know that it's safe. So the general community health volunteer training we did, trained a whole bunch of people, and then they were doing a train the trainer. They'd go out and train more people. But this picture here is a woman training how to use basically 2 Walmart bags on each arm to try and protect yourself while you're taking care of someone at home who's got Ebola. So if they vomit, how do you clean it up without infecting yourself and stuff like that? One of the hard decisions is, do you just pick one person to take care of that person? Because typically everybody in the family is going to take care of them, but then everybody in the family is at risk. But if you are picking one person, who is that person? Do you pick the oldest person, the youngest person, the mother, the father? Who's going to be chosen for that risk? Yeah, bad kid. Yeah. So we've got in the U.S. more developed infrastructure and infection control capabilities, although it doesn't look like it in Texas right now. We've got a lot of guidance coming out of CDC daily. They're changing their guidance and adding more stuff to it, so we're pushing that all out to the health department. So I'm trying to wrap up quick here. So we have our first cases in the U.S., so we have 8 cases now total. We had 4 healthcare professionals and 1 photographer who came here. We already knew they had Ebola, and they've gotten cared for, and I think they've all survived. But then we had the 1 Liberian man who came, and he died, Thomas Duncan, and then the 2 healthcare workers at this point who've been infected by him. So We do not have Ebola virus in Kentucky. That's the main point here. So critical clinical questions is, do they have a fever and maybe some of those other Ebola symptoms, and within the past 21 days, like I said before, have they traveled from an area with Ebola virus? Have they had direct contact with body or blood or body fluids of a patient with Ebola? Have they handled bats or duikers, these little antelopes, or primates from disease endemic areas? Or have they been to a funeral and handled a dead person who's got Ebola or could have had Ebola? If they don't have answers to those questions, then you're in trouble. But if they have answers to them and they're truthful, then you're in good shape. But the bottom line is, if they have those risk factors and the symptoms, then you've got to treat them like they have Ebola until you can get them tested and know. And so remember that you might not be able to get a good valid test for 3 days, so that may take a little bit of time. So supportive treatment only, rehydration, oxygen, static blood pressure, all that kind of stuff. There are some other experimental treatments out there now. ZMapp is the one that we've heard about. There's some others they're working on. Of course, plasma transfers they've tried, and those may be effective. There's a lot of things we're trying to do, but it's too early to see whether most of these are effective or not. And so safe clinical care, of course, is proper use of PPE. And don't do those invasive procedures if you can avoid it. Only use trained nurses. Now, we say not family, but, in the case of a kid, a child, they may be distraught and, you can't give effective care without the parent being there. So how do you handle those situations, and how do you make it safest for everybody? Of course, disposable needles, single-use thermometers and blood pressure cuffs, oral rather than IV medication if possible. Have dedicated staff, and that's a mistake they made in Dallas at Presbyterian. They had something like 77 different staff people who were exposed to this guy. Well, gosh, why didn't they just have like 12 people that were dedicated to that one patient, and that's all they did, so they didn't expose all of them. Oh, sorry. And of course, medical waste management is one of our biggest issues right now. How do you get rid of all the waste? So patient discharge, I'll just say quickly, the person needs to not have symptoms, and they need to test negative a couple times for Ebola. And even so, they need to be told not to have sex because they might have Ebola in semen or breast milk or things like that. Well, breast milk for breastfeeding. But in Liberia, we call it man-woman business. You can't have man-woman business for, they say, 3 months. None of that. Okay, and oh yeah, just one thing. Absence of fever does not mean that they're cured yet, because in late Ebola virus, the fever might go down. So you need to be aware of that. Not that you guys are going to be caring for patients. Laboratory, yada, yada, yada. There's all kinds of guidance, tons of stuff out there. I'm just going to flip through that because I need to get done. Do we think it can spread in the U.S.? Well, obviously, we've had some cases. Are we going to have a West African-style outbreak? I don't think so. But that depends on people being truthful and honest, and us doing our job and keeping up with the contacts and patients and stuff like that. So that depends on us, yeah. So I think we've got the ability to keep it contained here. So we're doing a whole bunch of stuff in Kentucky. I'm going to wrap it up because I'm over time already. Questions? No time for questions. So.
I stood up and I made Captain nervous. Yeah, I made Captain Thurman nervous. Are there any questions from the field? We certainly have time for questions if y'all have any.
Sorry, I talk too much. I got lots of talking in me. So.
Yeah.
So I'd be happy to answer any questions if there's a moment.
I don't have a question, but I have a comment. The reason I was late, I had to take my baby to the pediatrician, and I called to see if I could get an appointment. We set all that up, and then she said, and I'm sorry, but I have to ask you this. Have you or your child been to West Africa or had contact with anyone from West Africa within the last 21 days? And I said, no, but I'm really glad you asked me that.
That's great. I will say that's the one key thing, if you can all get that in your heads, is all you got to ask is that one question. Have you traveled to West Africa in the last 21 days? That will solve a world of problems, because if you get a yes, then you start asking some more questions. If you get a no, go about your business.
And then I had to fill out a form, and question 1 was, had you traveled? And if you said no, you were done with the form, and if you said yes, then you had to proceed on to these other things. So I was just sort of like, hey, somebody is listening, Yeah, I was impressed.
Yeah. All right.
Doug, do you want to advertise your brown bag presentation?
Oh, sure.
Because there may be folks on the air with us today on the ITV who may want to share with their colleagues another opportunity.
Yeah, so on October 22nd at noon, we're going to do a brown bag session, which is also going to be on ITV. Just basically the same talk, so if you've been here, don't need to come again, but unless you like listening to me babble. But for those who couldn't make it, or other folks, you're welcome to attend that. So you might want to let folks in your health departments know that we'll be doing this again.
Yeah. And both today's session and next Wednesday's session will both be taped and archived and available on Train.
Yeah. Okay.
Thank you.
Thank you.
For everything. Appreciate it. Allison, you want to come on up?
Sure.
We've got 5 more minutes for those of you all who can stay with us. Thanks again, Dr. Thurman.
Thank you.
Allison Taylor is policy advisor in the commissioner's office, and she's going to just provide a brief overview and answer any questions that y'all may have about the recent change in the administrative reference about the caregiver affidavit. So I'll turn it over to you, Allison.
All right, thank you. I don't
Thanks
have
for
to do
coming.
anything, do I?
No.
Because I've never done ITV before.
No, you're good. I'm going
Okay.
to put the camera, make sure the camera's on you.
Okay. So most of you know in the last session, there was an amendment, well, there was an addition to Chapter 405 of the Kentucky Revised Statutes that allows for a caregiver to fill out an affidavit to allow them to consent for medical and educational services for a child under 18. We sort of drafted an affidavit that I think you all have. This is not something that has to be used, but there have been questions about what do I tell people to put in this form? You know, do I hand them the statute and hope they figure it out? They don't have to go to a lawyer to get it done. They can bring in their own affidavit on a piece of notebook paper, and you should still accept it. But just to make life easy, if you wanted to give this to someone, you could. And this has been approved through our Office of Legal Services. The Department for Education is also using this. The form that we have addresses both medical care and educational consent. So there are a lot of ins and outs to it, and they're all spelled out in this affidavit. Probably the most important thing that you need to know is that if you're acting on good faith and they're completely lying, you're protected. You don't have to investigate, are they telling the truth, unless you have actual knowledge. So a parent calls and says, my crazy aunt is getting ready to bring the kid in and she's got this fake affidavit. Then you don't accept it. But you don't have to know anything other than that to be able to accept it and be covered and act in good faith. It's up to the caregiver to tell you if this has been revoked. Every year they have to renew it. So you keep it in their file, and if you don't hear from them that it's been revoked, then you're at no liability for accepting or providing treatment. Now, I think that the real reason I was here was that there had been some questions about it. So I'll do my best to answer if anybody has any specific questions about the new, the law or the affidavit itself.
Are there any questions from the field for Allison?
I just have a quick question.
Sure.
We've had several families that have exchange students coming in their home that do not have medical release issues. Would this affidavit work for them as well?
It would not, because under the statute, they have to have a relationship with the child, a family relationship. So even the neighbor, who's like the grandma of the neighborhood, that she's taking care of the kids or whatever, this would not work. There should be some process for a foreign exchange student, I would think, paperwork-wise through the school or the program or whatever, that they would come, with appropriate forms. So this would not work for it. In fact, part of the affidavit, I am Allison, and and I'm the caregiver for Joy, who's my sister, and she's under 18, and she lives in my home. Those are the 3 things that they have to have. They have to be a relative, they have to be under 18, and they have to live in the home with the person. And this does not affect orders out from court orders or, for example, I have a form on file at my pediatrician's office that my mom can take the kids to the doctor, so other consent forms like that. This is just for those situations that I think a lot of communities are seeing where, I think the majority of the cases, the parent or parents are drug addicts and grandma or aunt is raising this child without any court orders or anything going on, but they have no ability to go to school and register the kid or take the kid to the doctor when they're sick or to get their shots. So I think that's the time that you're going to see this most often. Now, the parents have to sign the form unless the person can articulate why the parent is not available to sign the form. So, mom's a crackhead and I haven't seen her for 3 months and she's not able to sign the form. If they're swearing to that on the affidavit, you're covered.
So what you're saying, and I've not seen this, I don't know where I've been, you'd think I was somewhere.
And it just went into effect in July, so it hasn't been out there that long.
I'll resend it, because I must have just completely that's not like me, but I did it. If they have an order of temporary custody,
Right,
the parent can sign consent.
right.
The person who has the child cannot. So what you're saying is I can get this affidavit, give it to the grandparent to get the parent to sign.
Yes.
And bring it back, and it will take precedent over that temporary custody order.
We won't take precedent, but it will give them the ability to consent.
Okay. Well, I like it.
Now, it doesn't bestow any kind of custody, you know, it does nothing more than just say, I can register the kid to school, I can bring the kid to the doctor. It's, you know.
Kind of a go around.
Yes, and I think it just came
This
from.
will, you know, like if they have temporary custody now, the WIC program, you know, requires that yellow sheet where you can't poke their finger. This will allow us to do the services that we normally couldn't do, like lead, hemoglobin, vaccines.
The only thing, there are specific exemptions from this, and I'm just going to tell you what they are. You cannot do any procedure to terminate a pregnancy, HIV or AIDS testing, drug testing, or any other testing for which a separate court order is normally required under law.
So that brings us to the same
But
issue.
I don't know, and I'm not familiar with whether you need a court order to do a finger test for a lead. I mean,
What happens
so.
is when they sign the original consent on the CH5, and I believe it's still there, but someone will correct me if I am wrong, the issue comes in with, all right, you've poked the child's finger for WIC, but then somehow you have had an exchange of blood with that person. You need to be able to test for HIV and hepatitis. And that's where that little statement that you can't do HIV testing without a court order becomes an issue with invasive procedures.
And you know, we have actually sent this specific question to our Office of Legal Services, and it's been assigned to someone, and I have not gotten an answer
Okay.
yet. I
So
can't
that's
give a
still-
legal opinion on that.
Thank you.
But yeah, so hopefully someday I'll be able to give you a legal opinion on that. It just won't be my opinion. So
Well, see, that's the problem that's always been even with the power of attorney. The power of attorney has that statement in it too, that you can't do HIV testing without, you know, a court order, which, you know, you want to, in the next sentence, it says you can give vaccines, you know, because it's, you know, based on federal regulation, whatever. But if you give vaccines and this child is not cooperative and you stick yourself with the same needle,
I understand where you're coming from. I just don't know the
you
answer.
just check the child, and that's, you know, and that's okay too, but you get a little quicker idea of what's going on rather than having to have immediate preventive treatment to prevent HIV or
Right.
AIDS. All right, my dear. Well,
Sorry, I don't have an answer on that one, but the answer is at least in progress, so hopefully we'll have an answer.
Yeah.
Yes, ma'am.
This doesn't supersede if the grandparents have a permanent sole primary custody order from the court,
Right.
then the parent, and they
Right.
have all decision making.
So one of the things that it tells you is that, one of the things that they're swearing to is that no other party has legal standing in custody issues other than the parents. So if I'm the aunt, but grandma has this custody order, grandma's still the one that has to consent. I can't supersede grandma. The parents can't supersede grandma. And they're swearing to all this, and you have no way to know. I mean, I don't have to tell you all. These poor kids can get passed around to 42 family members. But, I mean, it's a Class A misdemeanor to lie on this. And so the penalties for a Class A misdemeanor are up to a $500 fine and or a year in jail. So they're swearing and saying that they understand that that could be the penalty. And so that is not your concern at that point. Because a lot of people were like, oh, well, how do we know if it's true? They're just saying it and it doesn't have court signature. Well, I understand all that, but you don't have to worry about it. This is basically the answer. I think I know what they were trying to effectuate, and it might just be hard, they being the legislature. I think it just might be hard for us to get used to it because we're so used to court orders and, you know, all these other requirements. And like I said, don't get too stuck on this form. This form outlines everything that their affidavit has to say, which is all outlined in statute. It goes from A to N, all the things that the affidavit has to include. So, but they can come in with their own written, as long as it's notarized, it's a sworn statement that you can accept if it has all these things that the form requires. All right, that was easy.
Thank you,
All right,
Allison.
ma'am, you're welcome.
If you all do have any other questions about this new policy, you can contact Allison Taylor in the Commissioner's office, or Janet Overstreet in Local Health Operations. They worked very closely hand in hand on that, on the development of that policy and the form. So thank you, Allison, for answering those questions. So that wraps up today's Public Health Nursing ITV. I apologize we went over a little bit. The next ITV is December 18th. We'll be 1 week away from Christmas the next time we meet. So have a great day, and make sure you get your flu shot. I know many of you all are having your flu clinics right now. So thanks for all that you do for public health nursing. Bye-bye.